promoting healthcare policies and kind of the weird history of it coming and going. So with that, if nobody else has any introductory comments, seeing none, we'll turn it over to Ms. Davis from the governor's office. Welcome, Jen. Oh, we are live just in time.
Lucky me.
Welcome, Jen. Floor is yours.
Good morning, committee. Jen Davis. I'm the Governor's Health and Human Service Policy Advisor. Thank you for having me here today to talk about the Wyoming Healthcare Authority and the work that's been going on with this, as Chairman Zwanitzer shared over the last 6 months intensely, but really has been a conversation over probably the last couple of years. So I just wanted to, you all should have a draft of the document we put together related to the Healthcare Authority, which came out of the Governor's Health Task Force. And so this morning, I just wanted to share with you a little bit about how this came about, why we're discussing it, and really to get clear on what the purpose of it is and what it is not, because it is not the end-all be-all for healthcare decisions in Wyoming. So the purpose of this is to really utilize the expertise of the public and private sectors to inform conversations and make recommendations to you all to establish a Wyoming healthcare strategy while supporting public information and education. The mission of this group is to engage in collaborative decision-making for improved health outcomes and economic diversification. And the vision really is a comprehensive healthcare system that supports healthy living and economic security. As we talk about economic diversification and economic security in our state, healthcare is a cornerstone of that. If you don't have healthcare in an area, it's really hard to have economic development and stability. So the Healthcare Authority is really based on looking at 4 essentially pillars of this. It's looking at healthcare accessibility. So someone's ability to access healthcare in their local areas, what does that look like? Healthcare affordability, ensuring that people can afford the services that they're seeking. Quality of healthcare, ensuring that people are getting quality for what they're paying for. And then innovation in healthcare, making sure that we are staying on top of the current changes in the healthcare environment, which I know all of you know happens on a daily basis. And so really ensuring that we have experts who know where to look for those new things coming out, know how to analyze those and interpret those and bring them back for good recommendations that fit into the Wyoming landscape. So what I would like to do is just quickly walk through the document that you all have on the Healthcare Authority proposal. As I mentioned earlier, really the purpose of the proposal is really thinking from a systemic level on healthcare. That is big. That looks at your committee, that looks at Department of Health, that looks at private sector insurance, that looks at providers across the state. The healthcare system is very large and very complicated. So this is really looking at addressing healthcare from a systemic approach. So some of the historical background is Wyoming in the past has had healthcare commissions. We had one in the 90s under Governor Sullivan. And then there was another one in the early 2000s, 2003, one was started. Those committees were comprised of public-private sectors, were appointees that were tasked to come up with recommendations. There's long reports on both of those commissions that you can look at. Happy to share those with any of you as well. But it won't be surprising to any of you that what we found in digging into this over the last couple of years is that unfortunately, many of the recommendations that came out in the 90s, that came out in the early 2000s, guess what? Are the recommendations that came out in 2023. A lot of the things that we have been aiming for in our state just have not happened for a variety of reasons. Again, the system is very complicated. But what we found is those commissions, while they were doing their work, they put the recommendations forward, but then they ended. So then there was no continued conversation after that to make sure that those recommendations continued to move forward, that those recommendations were still appropriate. They just kind of fell flat. And then we saw the same thing in the early 2000 commission. So what we want to propose in this healthcare authority is that we have an entity that is stood up for the long haul, so that not only does this authority work with you, work with the Department of Health, work with the private sector, with all of the parties involved, and makes recommendations that have been vetted and brings those forward to all of you for policy decisions, that at the same time, then after decisions are made, that there is still a body continuing to look at that and make sure that those recommendations continue to move forward. And again, not all of the recommendations would require legislative action. I mean, there are many things we can do in healthcare just by coordination of services that may not need legislative action. So again, that's the point of having the experts and having individuals from state agencies, representatives from this committee, and then the public on there so that we're truly looking at it from a comprehensive standpoint. If you go further past the historical background information in the proposal, you'll find that we also described a little bit of the history of the Governor's Health Task Force. This actually started out of the pandemic when the governor put together 5 committees. One of them was health, that really looked at ensuring that we had an appropriate health response for that. And then after that was kind of in motion, the governor really wanted to look at cost and access to healthcare in Wyoming. And so that then developed into the Governor's Health Task Force. That task force was very large, has about 100 individuals who participate in that as the large group that really came together initially to talk about what are the issues that we're currently seeing in the healthcare system. From that, they broke that up into specific committees. One committee was really looking at healthcare infrastructure and payer structures, and that developed into the kind of the executive work committee. And then there was also a committee that looked at aging, social determinants of health, and then primary care. So those were the initial groups that came up of where we thought we should focus. Beyond that, then that was kind of the time around all of the CARES money and the ARPA funding. And so the group really put together some recommendations on how to use some of that to help with some of the things we were seeing in the healthcare infrastructure. So as you all know, many of those things passed through the legislature, like expanding 211 capacity, putting funding in for the Family Resource Center network, which is now up and running. We have 17 of our 23 counties engaged in that right now, and the other 5 coming on board, as well as the reservation. Both of the tribes are also investigating opening that as well. So that is really then when we started to dig in. We had a consultant who helped look at infrastructure, things that we could look at in Wyoming for controlling cost and access. And then that came forward then with some recommendations of really digging into putting together this healthcare authority. So when we look at the healthcare authority, as we talked about what the purpose of it is, this is not to put everything through an outside entity. This would be really looking at systemic issues across the healthcare space. So not specific of, scope of practice. Those are not things that this committee would necessarily, the authority would be looking at. It would be looking at large things like what's on your agenda today, the OB deserts in Wyoming, super complicated, needs expertise to know what that looks like. And then letting that committee do the research, the work, and bring forward to all of you recommendations that you can consider for policy. So that's really the intent of the authority. The last thing that I want to bring your attention to is What we'd really like to do is this could get very large very quickly because, again, it's complicated. There's a lot of sectors around healthcare, but we really wanted to kind of replicate this related to the Energy Authority, really having public-private partnership in there. And so what we suggested for membership is making sure that we have a mix of ex officio members and then appointed members. So in the ex officio membership, you can see we have a representative from the governor's office, Department of Health, Department of Insurance, A&I, the Employee Group Insurance, Department of Family Services, and then the chairs of this committee. So those would be the ex officio group. And from that, what those members would do is participate in all of the work, but again, they would be non-voting members. Then you would have appointed members, which would consist of a licensed physician practicing in Wyoming, a licensed nurse practicing in Wyoming, a hospital administrator, an administrator from a federally qualified health center, a licensed EMS provider, a licensed behavioral health provider practicing in Wyoming, an administrator or dean from a higher education institution, a Wyoming business owner, a private insurance carrier or self-insured employer, a marketplace carrier, a tribal member, and then a consumer at large. Again, that doesn't encompass everybody who touches healthcare, but we also needed to think about a group size that would be cohesive to getting work done. But then they have the opportunity to create subcommittees at will and pull in other people that they need for expertise based on topic or whatever they decide to do moving forward. So that is really a quick overview of what the Healthcare Authority proposal is. There is a proposal in there for one FTE so that this authority would have an executive director to really coordinate the efforts, pull the meetings together, coordinate the research efforts, and do all of the documentation necessary to help support the recommendations to move forward. So with that, I will stand for any questions that you might have.
Question for Ms. Davis, Representative Ward.
Thank you, Mr. Chairman. So you mentioned voting members. What are they voting on and what authority will they have once they vote on something?
Ms. Davis.
Chairman Zawanitzer, Representative Ward, that's a great question. So the voting members on that would be looking at, so let's say the group would do research around, I'm just going to use OB because it's on our radar right now. They would look at a variety of different options, maybe looking what other states are doing, looking at what's currently happening in Wyoming, surveying that, coming up with ideas, and then the group would vote on an idea to bring forward to, if it was a policy decision, to come forward to this group. If it was something to go forward to the executive branch that could be done in rules and regs, they would vote on what those were to take forward then to the executive branch leadership. So their authority would really be to bring recommendations forward to the executive branch and to the legislative branch. They wouldn't have the authority to make those decisions until those were finalized by wherever those rolled up to.
Follow up, yeah.
Thank you, Mr. Chairman. So this proposal would need to be voted on by our committee and also by the legislature, the creation of a healthcare authority. Is that correct?
Ms. Davis.
Chairman Zawanitzer, Representative Ward, yes.
So for today, we're basically, this is on our interim topic agenda. This is a structure that I guess the executive branch stakeholder group has kind of brought forward as a recommendation idea, but certainly if we draft it into a bill, we would have another shot or two at it to tune it to, I guess, the way the legislature would like it to look. So really, this is more abstract today, a proposal, and then we would take it and structure it how we'd want in consolidation through the interim. Is that kind of the plan for the day in your mind?
Chairman Wanitzer, yes. This is really an opportunity for you all to look at what the stakeholder group has been doing. This is the document that they put together as a recommendation. And then looking at if this is something that you think is beneficial, then crafting legislation as we move forward. And again, to do a draft and see if we can get it to fit what everyone's expectation would be.
But yeah, follow up again, Representative Ward.
Thank you, Mr. Chairman. So I'm curious, Ms. Davis, your view of how you think you can combine two very different goals. So there's quality healthcare on the one hand and then economic diversification on the other. To me, they seem a little opposed to each other. So I'm curious how you see those fitting together.
Ms. Davis.
Chairman Zwanitzer, Representative Ward. You're correct in some of that. Again, healthcare is very complicated. And as we all know, sometimes when you push in on one end, it balloons out on the other end. So it's really the opportunity of looking at access, affordability, quality, and innovation, and how that impacts economic diversification really has to all come together in a conversation. And there may be opposing views on that, most certainly, which is the benefit of the authority, kind of like what you all saw with the bill that went through last session. You have opposing views, but you all come together, hopefully not in front of all of you, to argue and figure all of that out behind the scenes to then bring you forward something that hopefully lands somewhere in the middle, because they definitely can be contradictory to each other, but we have to try to find where it is based on the goal that we're trying to achieve. If you're looking more at the economic component of it, or if you're looking more to the access, because they very well can be competing sometimes.
Thank you, Mr. Chairman. Ms. Davis, will the authority offer government health insurance like Washington's healthcare authority? Do you have any thoughts concerning that?
Ms. Davis.
Chairman Zwanitzer, Representative Ward. No, we had not had any discussion around this. This entity would just be a group of stakeholders who would come together based on things that we hear from industry, we hear from you, we hear from executive branch, that we really need to take a look at and make recommendations for. It would not be an entity that would be directly doing a service. This would just be kind of an advising authority.
So similar then to the Energy Authority in many ways of industry. I guess healthcare is 20% of the Wyoming industry now, and it would be bringing together those stakeholders to do more in-depth research or conversation before it's spilled out and to the legislative branch. I mean, is it more research and more data and information, or is it more getting all the spectrums of the industry together to be in one place before it comes into the executive, legislative branches of government or to the private sector? Or can it be all of those things? I guess depends how broad we want to make it, but is that kind of what we're thinking?
Chairman Zwanitzer, yes, all of the above. I think it could be a little bit of both. Having the experts at the table to really know what's happening in the industry in Wyoming is key. I can make recommendations, but I don't sit in that industry anymore. So I don't know what's happening in the day-to-day. So having the industry providers really telling us about what the landscape currently looks like, and that looks different across Wyoming, as we all know. It looks different in Afton compared to Cheyenne, compared to Gillette. And so having experts from across the state who really are in the day-to-day is key for us to understand what the issues are. And then bringing that together, that group would also then do some of that research of, looking at what is happening in other states across the country that maybe are similar to us, where they're having success that we can learn from. Looking at the research data that's out there in the different healthcare realms, like in the OB, looking at, what does the data look like on maternal and infant mortality? So really pulling all of that data together is what their task would be. As you know, the Department of Health would be part of it. They have access to a lot of data. The insurance companies have access to data. looking at how we can really investigate all of those components, then come together with that group to make solid recommendations to you all so that you don't have to do that kind of work, that it's done behind the scenes. And what comes to you all is something that's already been vetted and looked at, provide you the research and the data and the information so that you can make an informed decision.
Representative Ward?
Thank you, Mr. Chairman. So you mentioned the Energy Authority. I believe their budget, or they just got $300 million in the budget, if I'm not mistaken. Would you be seeking the same kind of amount of funds?
Ms. Davis?
Chairman Zawanitzer, Representative Ward. No, but if you feel inclined, that'd be great. No, I'm just teasing. No, what we have in there currently is just an FTE for someone to coordinate the effort in there. You know, I think that's a discussion that you all can have based on, you know, if you want them to do something else. But if you're just looking at it as an advisory group to come together, make recommendations, and that we felt that the only budget piece that was needed for that was an FTE to just coordinate the efforts.
Representative Ward?
I swear this is my last one. Thank you, Mr. Chairman.
No problem.
So you mentioned things taking place behind the scenes. Wouldn't you agree it's better when the public is involved in their government rather than things taking place behind the scenes?
Davis, philosophical, but go ahead.
Chairman Zawanitzer, Representative Ward, that's a good question. And I don't mean it in the sense of being private behind the scenes, but that it could happen in this group to where when we have opposing views, which we know we will have, that they can have those conversations without coming in front of this committee and, just for lack of better words, wasting time having those arguments in front of this committee, that they can do those in this group, which would also be public meetings that people can see and attend and participate in and be transparent. But that then that part of it doesn't come forward to this committee. By the time they bring a recommendation, those things have already been hammered out, and then you can get to making quicker decisions based on recommendations and seeing all of the information that happened during that process and why they ended up at a decision. I hope that makes sense.
Yeah. Senator Hutchings?
Thank you, Mr. Chair. Jen, I'm perplexed at this whole process in that the way we do things now, you'll have a group and let's just say OB, they come to a legislator and say, hey, we have an issue here. We'd like to bring it before you. Can you sit with us and we'll give you all the details? And then I share my details with her and him. And we make decisions that way. What I see happening with this group, it's another layer. And then there's not a lot of confidence in the layers of the people, of the groups that I see here right now. Some of us are concerned about what we see happening in departments and in different portions of the medical community. So you're saying, let us take care of that. Let us give you the answer before you even ask for an answer or even try to figure out as elected officials what can be done. So this kind of bothers me in that you're trying to alleviate a process that seems to be working really well and insert, like I say, a layer that we are concerned about into the process. How do you feel about that?
Davis?
Chairman Zawanitzer, Senator Hutchings, thank you for the question. I respectfully disagree. I don't think our system is working well. I think sometimes constituents maybe come forward to all of you and you hear one side of the issue and not necessarily all the sides of the issue. And sometimes that results in policy that doesn't work for everybody. I think we have had policy that sometimes may work for one group, but hasn't really been considered the impact that it'll have on the other side. And that is key. When we talk about accessibility, that usually has a direct impact on affordability. And if you don't know that and understand that, the complexities of it, you might very well have created a bigger problem than what you started with. With all due respect, I think that you all have some expertise in this area, but you don't have a lot of the in-depth expertise about healthcare. It's just not what you do for all of you. Some of you do work in healthcare and do have more of that expertise. And some of you work in other industry, which is great. That's what makes the legislature work. But when we're talking about making complicated decisions, I think that it's imperative that we have industry, the experts who are doing these things and making the policy and implementing the policy that you all make at the table, because they have to implement it and it directly impacts them. So this gives another arm to help support you when that constituent comes to you and says, hey, this OB stuff just isn't working. I'm not able to keep my practice afloat. I want you to do X. You can bring that to this authority and say, hey, I know this is pretty complicated. We'd really like to dig into this. Can you guys help us? And that's what that is really meant to do. It's not meant to circumvent anything. It is meant to really dig in and make good recommendations on all sides and bring that forward to decision makers. And having the legislature, your chairs as part of that is why that is listed as ex officio members as well, because you are important to the process. So definitely not meant to circumvent any work that you all are doing.
Follow up, Senator Hutchins? Go ahead.
Follow up.
Mhm.
Do you feel that right now we don't have that ability to go to the experts and ask them these questions now? Thank you.
Ms. Davis?
Chairman Zawanitzer, Senator Hutchings. No, I think you do have that ability. I think what happens though is we end up with one-sided discussions very often, that we hear what the problem is on one side and not looking at the complexities of what it does on the other side. And so I think the ability is there now. I think this just gives you a much better opportunity to have comprehensive in-depth look at, whatever these topics are. And again, this isn't going to be every topic. This is really more about those systems issues around healthcare that impact all of the different entities around that has an insurance component, that has a provider component, that has a state agency component. These really complex issues. Some of the other stuff absolutely does not need to flow through that authority. This is really meant to help you in those complicated spaces that we also often end up in, because healthcare is constantly changing and is very complicated.
Okay, Representative O'Hearn.
Thank you, Mr. Chairman. I assume, Jen, that no authority or an FTE was put in place in the 90s and in the early 2000s. And that's why the conversation between all the different elements and authorities never happened. Is that true?
Ms. Davis?
Chairman Zawanitzer, Representative O'Hearn, I believe that there was an executive director on some of those. What happened is that after the recommendations, the commissions were just dissolved. So that FTE also went away, and those were, so what we're hoping for is really embedding this within government as well as public. And so we're thinking, based on what we did in the research, that this would, putting it in statute and making sure that we were comprehensive in the approach, that it would have more staying power. But again, there was an executive director, I know, on at least one of them.
Okay, follow up. Good. Other questions? Senator Bouchard.
Thank you, Mr. Chairman. Are you familiar with the term regulatory capture? So are you aware that they elect us to protect them from the experts? And regulatory capture is part of that scheme?
Ms. Davis, and you're familiar so far?
Yes.
Yeah,
Well, I'd like,
go ahead.
Mr. Chairman, I'd like your view on regulatory capture and how these kind of committees actually pull that industry in where the experts get to have the say and maybe control it for a better profit or profitability on that end. And that becomes the driving force. I mean, Obamacare was a good example. It was supposed to say become affordable healthcare. You know, we have to pass it to see what's in it. Didn't work out that way. The whole COVID mess was about taking federal money. The experts told us how it was going to work. If we look back, it didn't really, the experts were kind of wrong. More recently, we had experts, some of them in this room, that came in and said, we don't need to pass a law to protect children. And quite frankly, the experts that came and testified were looking at an organization, pointing at an organization that's just been uncovered, that it's just an activist group. It's not a medical professional group, but people were pointing to that. I'm quite frankly appalled, thinking that we're going to get experts in a room and come tell us how it's going to be because they have the better views. When I've seen this very committee, how we can't even help our prisons at one time. We had all the infighting and the different the different groups, the experts, and we couldn't get treatment for drug addiction in a prison. And I mean, it was a 3-year fight to get that done. So how is having a certain group of experts, handpicked experts, going to help us decide when everybody has an agenda?
Ms. Davis?
Chairman Zwanitzer, Senator Burchard. I think that good policy stems from a comprehensive approach. You have to have experts on both sides. As we know, there is no issue that doesn't have two sides to it. You have to be able to have those debates in a respectful, cohesive manner. That's what gives us good policy. When it is driven just by one side, you get policy that doesn't work. And so, in my opinion, when you look at pulling expertise to the table, and what I mean by expertise is people who are living it, people who deal with it every day. In there, you have a physician practicing in Wyoming. That's whoever applies to be on that committee. You have a nurse practicing in Wyoming. They live that every day. They work with the patients every day. They know what's happening. I don't. I don't treat patients in the state of Wyoming. They do. You all are decision makers who are elected by our constituents, and you also have a voice in that and need to be part of policy discussion. But many of you are also not practicing and working with patients every day and don't know what that experience is. If we don't have all the right people at the table knowing what the impacts are, we can't make good informed decisions. Good informed decisions is what leads to good policy. So I do think experts are necessary. How we define experts are different based on what side of the issue you're on, and that's okay. We have to have those discussions, but we have to do it cohesively and respectfully. And just because you don't agree with one side or the other doesn't mean that their opinion doesn't matter.
Follow up, Senator Burchard?
Thank you, Mr. Chairman. So during COVID, we had anyone who disagreed with what the experts said were either shunned. Some of them they were worried about their licenses being taken away. There were pharmacists that wouldn't fill prescriptions. There was a whole expert panel that they had only one side. Everyone else was silenced. So I just see more of the same with this kind of approach where there's handpicked experts. I don't, how are we going to go back? Is there any accountability to where that got botched? We haven't even discussed any of that. How can we fix something when we don't go back and look at what we already broke?
Thoughts, Ms. Davis? Somewhat rhetorical, but
Chairman Zwanitzer, Senator Burchard. I'm not completely clear on what panel of experts you're referring to on COVID, but I think there was good intention in some efforts during COVID to hear both sides. COVID is a hot button. I'm not going to deny that. There are definitely two sides to that issue. Some that believe in the way that COVID was managed and some that don't. And again, that's okay. That's the point of this authority is get in the room together and have these discussions and hash it out. Talk about what those are so that then at that point, when everybody's voice is heard, which we know takes hours and hours and hours, you guys only have 3 meetings in the interim. This gives that opportunity for that to happen. And just because they're an appointed member doesn't mean that people outside of those appointed members to this don't have a voice. It just means you have to have a group that's a manageable size for voting capacity. Anybody would be welcome to come and share their opinion that you can get to a good recommendation to bring forward to this committee or again to the executive branch to a recommendation out to private industry. There's only so much we can control through government. I mean, you make recommendations that go out to a variety of different entities. But again, that's the purpose. Have those discussions. I believe that everybody has a voice, whether you are not on the same page or not. Again, it's how you get to good policy. And your point about going back and looking at things, I think is relevant. When we make decisions, you always have to go back and continually look and continually change, which is the point of having an authority because everything changes so quickly. So I think this gives you a lever of individuals that can help you.
One more. Yeah.
Just one more,
Mhm.
Mr. Chairman. So I see other states, Washington State is one of them. And when you go to their website, it's just flowing with how great Obamacare is. When you look at another state, New Mexico in July, they're gonna implement this same or a similar plan with the healthcare authority. So, I'm not new to this. I mean, I understand that there's a push somewhere coming from somewhere else. There's somebody who's introduced this into this state to the governor, to the office. Somehow there's a push here because I can see it happening around the country. Is there, are you willing to mention some of the outside groups that maybe you've talked to nudge this in this direction?
Ms. Davis, are there outside?
Chairman Zawanitzer, Senator Burchard, no, there's no outside influence on this. If you look at the historical information that we put in there, we had one of these in 1993. We had one in 2003. This has been a concept in Wyoming for a long time. This doesn't have anything to do with outside influence. This has to do with what's right for Wyoming. If that were the case, we wouldn't care if the physician on the group was from Wyoming or not that we put in there. We were very intentional to say in the appointees, it has to be a physician practicing in Wyoming, not a physician who's just licensed here practicing in, California. It needs to be somebody here from Wyoming who understands Wyoming issues. We are here to do work for Wyoming citizens, and this does not have anything to do with what other states have done. Have we looked at what other states have done in their structure? Of course we have. That's good, responsible recommendations to make sure that we are looking at all of the different things across our country that are working and that aren't working, and that maybe makes sense for Wyoming. But this has nothing to do with anybody's outside agenda. This is for doing better for our Wyoming citizens, period.
Do you know how many other states have something, analogous to a healthcare authority? I mean, it's kind of an independent research data. I mean, we've mentioned 3 or 4 other states. Do we know how many have something similar to what we're trying to do here?
Chairman Zawanitzer, I do not know how many others there are across the state. There are a variety of states who have healthcare authorities, healthcare commissions. Some of them are embedded within state government. Some of them are completely like nonprofit entities. There's a variety of different structures across the country, but I don't know how many states have them.
Representative Penn.
Thank you, Mr. Chairman. Ms. Davis, there's a few things. I would agree with you that our healthcare system is not working well, though I might take a different approach and say the reason that it's not working well is because of government involvement. I think this has us going in the wrong direction. This public-private partnership situation is pretty concerning to me. My question is, why can't we already do this? You know, you mentioned that other states have nonprofit and organizations that do this type of thing. We already have the governor's health task force that they make recommendations, some of which we implemented in the session of 2023. So why this? Why now? We've been working on this for 20 years, where they've come and gone. We currently have something that is supposed to my understanding, do something similar. So why do we need something in addition to what we already have?
Ms. Davis.
Chairman Zwanitzer, Representative Penn, that's a great question. This would essentially become what has been functioning as the governor's health task force. Just because this has been under this governor, it certainly can continue into a next administration, but that was the point.
Yeah, go to the.
Sorry, I guess that means I'm talking too much. So as far as the health task force, again, that was created under Governor Gordon and has been doing the work as pretty much outlined within the document. The group really wanted to ensure that this continues. Like you said, why can't we continue it? Great question. They'd love for it to continue, and I'll let some of them speak to that. But the way they found to do that for it to continue is to put it in statute so that it does go on regardless of administration, regardless of the group of you who are supportive of that happening. You know, the next committee members may not be, but making sure that this is something that we have as a structure to help with decision-making around Wyoming healthcare. I hope that answers your question.
Any other follow-up?
Thank you, Mr. Chairman. So a while back, you related this to the energy authority. We have an energy authority. I also noted that you said that this could get really big, really fast. And I have concern about that. So as was brought up, you know, the energy authority now is getting appropriated $300 million. I imagine it probably didn't start that way. Very likely it started, and I would like to know the history if anyone understands what the history of the energy authority is. It probably started as a single full-time position. And the habit of government is it just gets bigger and it gets bigger and it gets bigger. And ultimately, we may not even still accomplish anything. And so I guess my question is, how do you see the future going with this?
Ms. Davis, we actually, in the Energy Authority, we started with pipelines and infrastructure, and then we actually got efficient and combined them. And it's kind of more of a success story of combining government. But go ahead, Healthcare Authority.
Chairman Zwanitzer, Representative Penn, when I referred to that this could get big really quickly, what I was referring to was when we established who the membership would be, because there are so many aspects of healthcare. So that was why we kind of narrowed it down to I think there's around 20 individuals on that, so that you had something manageable for a voting body. As far as the Energy Authority history, I think Chairman Zwanitzer has far more expertise in that area than I do. What I mean when we use the Energy Authority as an example is really just kind of based on their structure of how they look at the different hubs. So like in energy, they look at oil and gas, they look at wind, all those different things. So we kind of structured it based on their kind of hub and spoke model for structure. Again, I think as you all go forward, if you choose to put this into, you know, a draft bill that we look at and continue to dig into, I think it really depends on what you want them to do. If you have an expectation that they do something more than what's outlined, I would imagine you could give it an appropriation. The group really felt that it just needs somebody to help coordinate the efforts because it is going to just be convening individuals and bringing forward recommendations. So they did not feel that there was a need for additional funding at this time because many of the recommendations would go to, if it was a recommendation for, say, funding FQHCs or something, just as an example, that would go through the legislature anyway. And so their recommendations would be based on legislative action if it required an appropriation, not specifically to that individual authority.
Okay, follow up. I know we have some other people and going to try to keep us on topic, but Representative Penn.
Thank you, Mr. Chairman. Just one last question. So in here, it talks about how the board members would be nonpartisan. You bring up wanting to hear both sides of the argument. Looking at the list of governor appointed members, some of these are maybe they aren't partisan, but they're very one-sided in the direction that they tend to take. And so how do you, the concern was brought up, COVID, and this is reality. One side was silenced. People were not allowed to express other opinions for fear of retribution. You might be able to say that, well, their viewpoint was allowed. But if we're being honest, there are many things that were silenced in a way. And so how do you anticipate avoiding that situation when we have a single hospital administrator, a single, the dean from higher education institution? How do we get both viewpoints if there's a single person from that entity on the board?
Ms. Davis?
Chairman Zawanitzer, Representative Penn. The point for it being bipartisan is that we wanted these individuals to be there as the expert in their field, that we aren't going to ask what party affiliation do you have to be a physician on there. They may be a Republican, they may be a Democrat. It wouldn't be a question that would be asked. We want their expertise as a physician of knowing what they do on a daily basis at the table. Again, I think that hearing both sides of that, again, these aren't going to be the only people. If they're discussing, I would assume, if they're discussing an issue such as OB and the physician that you have on there is a orthopedic, they're going to be pulling in OBs from around the state that work in, all different areas of OB, whether they're family practice, whether they're OBGYN, whether they're doula, whether they're midwives. That's their role, is to pull those appropriate people to the table so that they have a voice and that it not be driven by party affiliation, but by what is happening in the field.
Okay. Well, I'm not going to get you hop off the hot seat quite yet. I know some other people want to testify in about 15 minutes. Representative Yen, and we'll go to Representative Hornock.
Mr. Chairman, thank you, Ms. Davis. I am confused about this committee's reluctance. I mean, I guess maybe just because it has the word authority in the healthcare authority. Again, this authority doesn't have any real authority other than making recommendations. Is that correct?
Ms. Davis?
Chairman Zawanitzer, Representative Ed, yes.
Representative Hornock?
Thank you, Mr. Chairman. Ms. Davis, thank you for coming and answering our questions about this, of which there are many. I've got a few, but so as I go down through this membership list, we have in the room today, we probably have more than half of the representatives of somebody that could fit in each of these categories. So I guess my first question is, we have, like you said, we have 6 days in our interim session on the Labor Health Committee for healthcare related topics. And I say that specifically with healthcare related topics because all the other topics got stripped from this committee. So we're just talking about healthcare related topics, thanks to the decisions of Management Council. So we have 6 days to talk about these subjects. The wheels of government turn slowly, and they're supposed to. There's a reason for the wheels of government turning slowly, but Why is it that we would need a healthcare authority to put together a task force where multiple members that are here in this room today would also be on that task force? So it seems like there'd be some redundancy. And you know, as an example, last year, we passed a prior authorization bill. We put together a committee that really dug into that. And that really worked well, but that came from this committee. So I guess I need more justification of why we would start another branch of government, another bureaucracy, basically, to cover something that is the responsibility of this committee.
Ms. Davis?
Chairman Sawan, sir, Representative Hornock, thanks for the question. I think your point is very well taken. What happened last year with the prior auth bill was great. That's the way policymaking should work. It should be done with a group of experts and a group of decision makers coming together. That's what this can do for you on a regular, ongoing basis. And then bring that back to all of you. Again, you're represented in this group. It isn't that you're being circumvented on that. So, and to your other point, you're right. This is the health, labor, and social services. All of your topics are health related. I think there's many of you on here who wanted topics related around labor issues. This could free up some of your space in there. Let this group help you to bring you things that don't take up all of your time during your 6 days, that they can bring you vetted recommendations that are several. It doesn't mean they're going to come to you with one thing and say, here, this is what we want. There'll be a variety for you guys to think about. And again, your chairmen are part of that group. And to really give you an opportunity to use your time wisely that you have. Again, many of you also have jobs that you're doing outside of this. This group's work would be to do all of that stuff during the interim to help you out.
All right, follow up, Representative Hornock, and then we'll get some public comment.
Thank you, Ms. Davis. Thank you, Mr. Chairman. Valid points. Thank you for that. Another question that that I have, I guess, is one of the we've kind of well, just curious about your personal thoughts and what would potentially happen, the recommendations that an authority would bring to this body. So, and you know, where you stand personally. Do you feel that if Medicaid were expanded in the state of Wyoming, that it would meet several of these criteria that you're bringing forward about the responsibility, the affordability, the access to healthcare? It would solve those issues if Medicaid were expanded in the state of Wyoming.
Ms. Davis, you are here representing the executive branch and the governor, right? So
Yeah.
I just want to make sure you said that when he asked for your personal opinion. You can say whatever you want, just you might preface it. Thanks.
Chairman Sawan, sir, Representative Hornock. Again, I am here representing the governor's office. What I will say to that is healthcare is complicated. I don't think there is one solution that solves everything. If there were, none of us would be in this situation that we're in across America. I think there are things that need to be considered. Medicaid expansion has been considered by this body for many years and has been spoken very clearly that this current body does not want that to move forward. The Healthcare Authority's job and the direction of the Healthcare Task Force from the governor was, I want you to look at all options, which means look outside of Medicaid expansion because this body hasn't wanted to move that forward. And so we have to look at all of the areas because, again, there is not one solution that will change affordability and accessibility for healthcare.
I think music therapy would help. With that, let's take some audience questions, get you off the hot seat. And we can put some more time in our next meeting for when the bill drafts before us to really dig into it. But is there other people here from the task force or the working group you mentioned who want to testify on the initial stages of us pursuing thoughts on a healthcare authority? Get people on both sides. Welcome, Ms. Bush. Floor is yours first.
Good morning, Mr. Chairman, members of the committee. Sheila Bush with the State Medical Society. We are in support of this proposal and look forward to hopefully continuing the conversation with you. I think a lot of the questions that were asked are really, really good ones, and they're ones that together we could work through and find best solutions for. I wanted to specifically talk about the prior authorization process. It's been mentioned a lot this morning. I think it is a great example of what we would envision this healthcare authority to be able to help support. I would also say that some, if not most of the success from that prior authorization conversation was because of the relationships that existed and continue to exist among the players that were on the industry side. So there are debates similar to that one happening in other states that don't go at all the way it went here for us. And I think that's absolutely because everyone has those strong relationships. And the way I see this healthcare authority further supporting that is that it fosters those relationships. It creates the opportunity for people to spend all day on a topic, if not multiple days on a topic, truly feeling like they heard every single different perspective and insight that there just simply isn't time for in a venue like this. Politics can inherently bring points of contention, and a healthcare authority could be separate from that and not be a place for tension, but instead a place for truly candid, transparent conversation about the pressures that exist and are alive and well in the reality of this industry. I think that's why you saw prior authorization do so well, is because those individuals outside of this committee worked really well together and there was trust. We were open about what was really on the line, what the true issues at play were. And those conversations were able to happen outside of the inherently contentious aspect of, I'm going to testify and represent a certain perspective in hopes that people with the true authority, which is all of you, vote in the direction that my membership or my industry would like you to go. And so the true value of an authority is that venue in which those conversations can happen right now. They happen at the governor's task force. It's a really great place for people to share, excuse me, all of the different sides of their industry. I think we all early on in the task force said, when we walk in this room, we're going to remove our hats that are our professional, my job to represent the medical society. And instead, it's my job to bring the expertise and the insights I've gained from working with that industry for almost 20 years. And those are different things. And in this venue, it is my job, and I'm hired to bring the voice of my industry or the members of my industry. And in that authority or in the task force today, instead, it's my job not only to still represent them, but to bring all of the insights and be very transparent about everything that's at play in the delivery of healthcare. And so Wyoming is siloed right now. We're a small state with a lot of really well-intentioned people. And we have a lot of meetings that all talk about sometimes the same topics, sometimes with the same people in the room. I was at the Medical Society for one of the iterations of the Healthcare Commission that was established by Governor Friedenthal in the late 2000s, 2007, 8 is when I was here. There's a report that came from that Healthcare Commission on the aging population of physicians. We don't have anything that's been updated since that Healthcare Commission was sunsetted because of administration changes. It's still the only document or true data source we have on really identifying what the aging population of professionals in this state look like. And I think it would be our hope and vision for the Healthcare Authority to be able to bring back some of that data, to break down silos, to make sure that there is an entity that's bringing all the voices together, that we're not duplicating work, we're not duplicating studies, we're getting the best data, and that we are bringing that data to you for you to ultimately make the decisions. And so with that, I'll stand for questions.
Real quickly, how much time would you say you spent on the PA discussion outside of what we're aware of? I mean, we had 3 meetings. We know you prep for them, but in that since our last meeting in September, hours or weeks, or how much would you say you spent coordinating internally before you brought the grand compromise amendment to us?
Mr. Chairman, members of the committee, hundreds? I honestly don't know. I mean, I would say from the Saratoga meeting until everyone gaveling in Cheyenne, at least every single day, I probably spent 3 to 4 hours. And so whatever that is multiplied by that many days then you're in the thousands, right?
Multiplied by 10 to 15 people?
Mhm.
Uh-huh. Okay. Welcome, Ms. Burke. Or any questions for Ms. Bush? Sorry, I should double check. Representative Hornak.
Thank you, Mr. Chairman. Quick question. You said that you gather outside of this meeting and you would then gather in the authorities setting and you would kind of take off your hats. What assurance, and have a candid conversation, what assurance could we have? I mean, we're all paid by somebody and we always represent the people that pay us, that give us our paycheck, that put food on their table. And, I know that conversations are a little bit easier, the back and forth dialogue, when you don't have to go through a chairman and, the formality of this type of a meeting. But there are reasons why this type of a meeting is a good setting for some things. Not so easy on other things, I understand. But I guess, is it truly possible to get in a room and take off your hat and see the other side and work with the other side and try to accomplish some of the goals of the other side when there is always clearly something pushing each one of us on our side?
Mr. Chairman, Representative Hornak, it's a great question with probably a nuanced answer. But yes, I think the answer to your question is yes. I represent more than 1,000 physicians across this state. And as you all might know and have received communication from and emails from, they have very differing opinions on a myriad of issues. And that's healthy. That's good. And so I am in those meetings when I say, let's take my hat off. I have the benefit of over 20 years at dinners and at meetings and at board meetings with those physicians and all of their opinions and all of the diversity that lives in their specialties and their expertise and their background. And so if I'm testifying before you, I have been given direction to represent a certain perspective on a certain issue. In a setting like a healthcare authority, there's not always a specific issue on the table. Instead, it's the insights of what are we going to do about a more broader conceptual question, like the cost of healthcare. And in that, you're going to have competing interests even within the physician community. There are a number of issues we could go through today that there's very different opinions between primary care and specialist physicians on what the right answer is for a number of questions. Here before you, I have to represent one of those because the board decides which perspective WMS and our board has all of those views. In a healthcare authority, I can speak freely about, these are all the things. This is what primary care will tell you. This is what a specialist physician will tell you. This is what the pressures are. Here's why. These are the pros and cons of both, because you have the time to do that. And there isn't a specific issue that we are seeking a yes or no vote from a committee like you on that issue. Does that help?
Okay, thank you. We have another Representative Penn.
Thank you, Mr. Chairman. So I appreciate that the prior auth bill was brought up because I think that's a perfect demonstration. I was thinking about that before and just didn't say it, of how important it is for stakeholders to get together and work out the issue. And I think it demonstrates that this can happen on the outside. organically, and that's how it should happen. When entities have an issue that they care strongly enough about, that's important enough or impending enough that they need to get together and hash it out, that's what needs to happen. I don't think that we need a authorized government entity to say, okay, let's get in the same room and let's hash this out. You mentioned that this would allow the fostering of relationships. Do you think that that's the proper role of government?
Ms. Bush.
Mr. Chairman, I think it's the proper role of government to ensure good policy, and good policy comes from everyone working together and there being trust and relationships. And so I would argue that without the healthcare authority this past year in prior authorization, where some of us at different periods were at significant odds with each other and big hurt feelings because we're human. There's feelings, there's opinions, there's thoughts. If we weren't in a situation where we had to see each other on a fairly regular basis because of scheduled meetings in the task force, I'm not sure it would have gone the same way. And we've all been friends for over 20 years. And so I keep looking at Denise because we were there. But I think maybe what's missed and what you guys weren't part of, thankfully so, was just how rough that got for a while. And I think without regular meetings, without being forced in a room to talk about other topics, not that one, but we were reminded of so many things that were bigger than us and bigger than that one issue. And that if we were going to get something done for Wyoming, we were going to have to really roll up our sleeves and do it. And that's because we were part of this larger group. And so I think it was in large part because of the governor's task force that exists now. And what we're all seeing is those of us who've been in this industry for 20 years, and probably we won't always be the faces of these entities. Some of you are really happy about that, probably. But I think that to put in place something, to experience something that worked so beautifully and say, well, what about it worked so well? And to piece that out and say, it's pretty fragile because it's really more of a product of the individuals who were involved in that at the time, not because we have a systemic process or a structure by which it can happen in the future on other issues. And I think that's what we've been working on. We all sat down and said, all right, these are examples of things that went really well. How did it go so well? And how do we in any way codify that and create it so that people beyond us and into the future can benefit from the same thing, and the people of Wyoming can benefit from those policies?
So I think from what we're hearing, we have this kind of fear of this huge behemoth healthcare authority that's going to control things. But at the lowest minimal end, you're really just looking for one position to coordinate kind of the healthcare working group. Because right now it's under the governor's office, and perfectly happy with that, but that's also a political entity that is pushing you in a certain direction. And so really, whatever this authority concept is, getting an outside person, one person, to coordinate what's kind of been I'm not sure, like a gentleman's agreement that came together from the COVID issues where you all kind of got brought together, thrown in a room, and now you'd like to at least have one person and some type of structure to continue this work, because it actually, depending on our thoughts up here, it's been working pretty well, getting you all together to kind of help do this, but you're just doing it really because either we forced it on you as a legislature with prior auth, or COVID forced it on you for response. But there's no structure. You're just all kind of doing it because, the governor kind of asked you. So ultimately, I mean, is that correct? This is really just asking for a position outside of the governor's office to keep you coordinated and kind of keep all these facets under one roof as, we go into the future.
Mr. Chairman, yes. The only thing that you said that I sort of took pause with was, I don't believe in the years that I've served on that task force that there has ever been an agenda, I don't ever feel like that committee was pushed in any direction at all. I think that there was a venue that was facilitated. We were given, the opportunity to be in the room around the same table to talk about a myriad of issues, including the shortage of emergency room physicians, which then quickly turned into, uh-oh, now we have an abundance of ER docs and no jobs. And what should we do? How do we unpack that? What are the conversations that we should be having around that? But I never felt like there was an agenda or a direction that was being pushed.
If there was, you wouldn't say it with her next to you, would you? But no, I'm glad to know that there wasn't. Representative Trujillo.
Thank you, Mr. Chair. I just have a quick question because I'm trying to understand how we're going to add a level of bureaucracy to this. If everybody has a job within their industry, why can't you just have a meeting? Like how many employees are through Department of Health? How many employees are through all the industries? What's wrong with just having task force meetings like this? Why do we have to add another level? I mean, everybody's getting paid to do a job. And we can have, why isn't there just communication between agencies and industry to get this done and present it to us?
Who wants that one? Ms. Bush, go ahead.
Mr. Chairman, Representative Trujillo, I think your question was, can't you just have a meeting? Of course, the answer is yes. Everybody can just have a meeting. I think the difference is, so, later on the agenda is maternal health, right? That's a great example of, even within the physician community across the state, you're going to have really different ideas about how we're going to tackle and address maternal health. A healthcare authority could ensure with a level of prestige is the wrong word, but it's the one coming to mind, to say you have an invitation from the Wyoming Healthcare Authority to please be present at a meeting on X date and have family physicians with OB residency or an OB fellowship, to have obstetricians, to have specialty maternal fetal medicine physicians all in a room to really maybe spend 5 hours just even on the physician perspective and the diversity of opinion that lives within that, to say, if you were going to fix this problem and handed a magic wand, what would you say the answer is? Me having a meeting doesn't get that. It doesn't achieve the same goal in the same way as the healthcare authority saying, this is the problem we're digging into, and these are all of the opinions we want to hear from. And we want to make sure that we hear from doulas and nurse midwives and lay midwives and the physician components, right? Like all of them have to be there, and they have to be given more than the 2-minute limit that's often given in legislative testimony. Please don't.
Yeah. You have a follow-up real quick?
Follow up. What is your job?
Go ahead.
My job, my title, or what is my job?
What is your job? Like, what do you do? Do you meet with all these different entities to have their opinions so then you're properly prepared?
Mr. Chairman, Representative Trujillo, my job as the director of the Medical Society is to be a liaison and a coordinator and the voice of physicians in formal meetings like this when they can't be here because they're seeing patients. That said, I can't ever, no matter how long I spend in this job, I will never have the true clinical medical expertise. I can talk with them all day long and hear their stories and try to learn the vocabulary and try to pronounce it right. I can look to Chairman Baldwin in desperate times of like, I'm in way over my head and I have no idea. But without those physicians there and without all of those different specialists saying, this is my perspective and this is my perspective, and these are the tensions that exist even between those two physician specialists, I'm not the expert in medicine. I'm the voice of a nonprofit membership organization that guides me to come and do my very best to connect you with them and to express their voice on issues in a very specific way. But I'm not them. I'm not a doctor and would never pretend to be. And there's a different value. My voice here in the legislative hearing is to say, this is what the 1,000+ physicians that I represent have decided on through our governance structure, and to always be very transparent with you to say 100% of our membership doesn't agree on 100% of anything that we do. That's just life. But that's different than saying, all right, let's roll up our sleeves and let's spend 4 hours talking to a list of physicians, all of whom I represent, to give a very specific clinical background and expertise on a topic.
Okay, Representative Ward.
Thank you, Mr. Chairman. Ms. Bush, certainly you would agree that significant trust has been destroyed among consumers in the last 4 years, consumers of healthcare. So how does including only one consumer member at large among 18 or 20 members of a task force or a healthcare authority help to restore that trust?
Ms. Bush, if you want it.
I don't know that I certainly would agree that all trust has been lost. People still go to the doctor. All of my members have packed schedules all the time. So if there wasn't any trust, I don't know that they would be going to the doctor and continuing those appointments and entrusting their health to those individuals. Maybe that is debatable. But I think when we talk about the number of consumers maybe it needs to be more. I think our idea was to actually have 2, and one of those was sort of captured in the tribal. There's 2 at the bottom, right? Excuse me, right above the consumer. There's a tribal representative. I think we also wanted to make sure that we had that constituency represented. And in the conversation, we thought that that could also kind of check another consumer box. We were very intentional about making sure that the consumer voice was heard. And if through these conversations, hoping that they continue, it should be more consumers, then that's a conversation we should have.
Ms. Burke, welcome.
Thank you, Chairman Zalanis and members of the committee. Denise Burke, and I want to make it absolutely clear, I am here in a personal capacity. No one paid for me to be here. I'm doing it because I have been working in healthcare in Wyoming for over 30 years. I was first appointed to the governor's task force. At that time, I was health policy for the Department of Insurance. But I came to the Department of Insurance having been Associate Dean of the Law School at the University of Wyoming, where I taught health law and policy. I also was the State Medicaid Fraud Control Unit Director. I was the attorney for the Department of Health. So I have years of experience working on healthcare issues in Wyoming. I've continued to serve on this task force because I believe it is so important. And I think that the examples that we have given to you of why the authority is needed is for continuity. We have had good work done in the past, and it has fallen because there was no means to carry it on further. Will I be able to continue in a personal capacity doing this? Well, at some point, my accountant's probably going to say, you're retired and this is not really economically feasible for you to continue. It is absolutely on my own. Why I chose to come here today is I thought it was important for you to get a visual representation of the diversity of perspective that comes to that task force. And Sheila is exactly right. The prior auth work was hard. And there has to be a way for that continuity to continue to give you all the kind of quality research background work in order to enable you to do your work then. I'm open to questions. I would reiterate what both, I get emotional about this because I've worked on it so long. And we have not made tremendous progress in those 30 years. We still have gaps. And I think the issue that perhaps the public doesn't get is how big healthcare has become. And that is not anyone doing, that's not the legislators' fault. It is what has happened in the healthcare world. And this authority is one means to bring multiple voices together to try to address this huge issue that we have looming in our state.
Okay, Representative Hornock.
Thank you, Mr. Chairman. Thanks for coming today and testifying. I imagine that in the list of membership that we got, your name would probably be high on the list for that if this authority were formed. So in your personal capacity, is it your personal opinion that if Wyoming expanded Medicaid in this state, that we would meet a lot of the requirements, a lot of the problems that we're facing in the healthcare industry that are listed as as things that this health authority is trying to solve.
Ms. Burke?
Chairman Swanner, Representative Hornock. It's a great question. I think I'm not sure I know how to answer that because the responsibility of the task force is to look at all options. Would that be something that the committee would look at, or the authority? Absolutely. But we may conclude that that would not be the solution and the recommendation would go forth. But we again may conclude that it is. So I can't, that's one of those questions that I think it would be inappropriate for me to surmise what the decision of the authority would be.
Other questions, Ms. Burke? Seeing none. Thank you all for being up here on the hot seat. Oh, but we have a fourth chair. If you want to go, you can. You can stay. Welcome, Ms. Roday. Excellent. Heather, floor is yours.
Morning, Mr. Chairman, members of the committee. My name is Heather Roday, and I'm here from Blue Cross Blue Shield of Wyoming. Just wanted to encourage the discussion to continue and move forward with the bill draft. We're short on time. You've heard all the reasons. Just wanted to chime in and offer support for continuing on the conversation. Thank you.
It's fair to say from your industry on who pays for healthcare that you have found the working group, positive. And we heard from doctors, we heard from healthcare. You represent the paying side, but it has been worthwhile. And any complications, any issues, any problems, any personal anecdotes you want to share, I guess is my question.
Thank you, Mr. Chairman. Yeah, we've talked about what happens on one side. You push the balloon on one side and the balloon comes over here. Lots of time over here is the cost of what we end up doing. And so having insurers in the room to have that discussion about, okay, this is great, but please understand that these are the costs that might be incurred is a valuable part of that conversation and very needed, has been helpful thus far.
Thank you. Questions, Representative Hornock?
Thank you, Mr. Chairman. So again, a part of the membership lists insurance providers and things. So I imagine that your name again might be the top of the list if we enacted the healthcare authority. I'm curious your personal opinion. If we expanded Medicaid in the state of Wyoming, would we solve a lot of the problems that the healthcare authority is looking into?
Ms. Roday, go ahead.
Mr. Chairman, Representative Hornock. So I represent Blue Cross Blue Shield of Wyoming. And I, like others, I think that, we've had that discussion and I think that the authority would, with those other members, have their thoughts that would move the discussion forward, whether that's an option or not. But that would be up to them to decide.
Mr. Hannes, welcome.
Thank you, Mr. Chairman, members of the committee. Josh Hannes with the Wyoming Hospital Association. I know you all are probably eager to move on to your next topic, but sitting in the room, I had a thought and perhaps a suggestion for this committee. I know we'll have a lot of conversation. There's a lot of people here to talk about the OB topic, which is quite broad and complicated. There might be an interesting experiment where during this interim, the governor's task force is currently constructed, could take on that topic as a way to test this idea, and those results, certainly being brought to you and along with your participation to see, is this a structure and a framework that's helpful for developing policy on some of these healthcare issues? So just wanted to offer that as a suggestion and perhaps a way to test this and see how it works out in reality rather than in a hypothetical discussion.
You want us to give you more work? Okay. You guys all enjoy meeting. Questions? The hospitals? For Jen, okay.
Trying to make Mr. Chairman, I'm
Mike
trying
on. A little closer, thanks.
to make the connection between Medicaid expansion and a healthcare authority. I felt like there was kind of a big reach there. Jen, you want to comment on that?
Chairman Zalon, sir, Senator Dockstetter. I think the conversation about Medicaid expansion is, again, nothing new to the state. It's one lever that people have looked at for controlling costs and for increasing access. It certainly has been conversation within the health task force about what Medicaid expansion can offer to the state and what it can't offer. So I think that, again, Medicaid expansion, whether we do it or don't do it, does not solve all of the issues that the Healthcare Authority would look at. That is one small piece of the puzzle. And there are varying opinions if it would increase access or decrease costs. It's certainly discussion that has to be had in our state. And as you all know, has been had over and over again. Department of Health continually updates on that on an annual basis, a report that goes to the legislature. So it is something out there. Again, I don't think there's one solution that solves anything. And so continuing to have the discussion about Medicaid expansion has proven not to be something that our legislative body wants to move forward with. That recommendation has come from a variety of sources over the years, not the Health Task Force. So again, I think that it has some relevance in healthcare discussion because Medicaid is a piece of our healthcare system, but we have to look at all of the other options that are out there. It certainly is not the driving force for our healthcare authority.
Thank you, Mr. Chairman.
And it's fair to say, with a strong statement from the legislature on not passing Medicaid expansion, perhaps even more need for this authority to come up with some solutions that would otherwise be solved and would require greater collaboration and coordination if we're not doing Medicaid expansion on how to solve some of these access to care and fiscal issues in our state. Is that fair?
Chairman Zwanitzer, that is fair. And that that has been the governor's position as well, is that we need to look at other options. It's been very clear that has not been an appetite of the legislative body. So what else can we do in Wyoming to control healthcare costs? We're one of the most expensive states in the nation for healthcare premiums. And that is due to many factors. So again, we have to look at all options. We can't silo the conversation into one topic that would control cost and increase access. That just doesn't exist.
Representative Ward, one more.
Thank you, Mr. Chairman. There's at least one member of the public who wants to comment on Zoom. I just wanted to let you know.
Thank you. I don't have the person listed on registering by yesterday, but I'll look at it up. Any questions for people before us? Senator Bouchard.
Thank you, Mr. Chairman. So we've had a discussion about Medicaid expansion. And I think that we're trying to get to the answer, which we already know, because a lot of people in this room have testified in favor of Medicaid expansion. And it will be those people that will be on this new, we stand up a new part of government that says, hey, we're the experts. There's an agenda. I mean, all I got to do is look back in history here. And there was a constitutional challenge in court to Obamacare. And just to quote the Blue Shield Association president, we are pleased today, and this is what happened, the courts did not hear the constitutional challenge, or they dismissed it, I should say. We are pleased with today's decision dismissing the challenge of the Affordable Health Care Act. The Affordable Health Care Act has made healthcare more accessible by providing 31 million people health care coverage. Right now, 90% of Americans have health care coverage through their jobs, the individual market, Medicare, and Medicaid. So we've stood up this whole system. And now we have people on one side that want to get paid for their work, of course, but this system is where it's all headed, and that's where the agenda is. So I think the public has already seen this. They've already seen that, let's pass it so we can see what's in it. Now they see what's in it. I just don't, I want somebody to tell me how the people who get paid, their representatives being on this board, protecting their paychecks, is somehow going to make this system that the government stood up better.
Ms. Tibbs, go ahead.
Chairman Zalon, Senator Bouchard, I want to make one thing very clear. When you look at the membership that is suggested there, it does not say the associations in there. It says a physician practicing medicine in the state of Wyoming. It does not say the hospital association. It says a hospital CEO. We are not appointing the associations here. And I will tell you that discussion happened. And we were very intentional to make sure that it was not those entities represented on there, that it is actually the industry doing the job every day that is on there. Will there be some physicians who want Medicaid expansion? Of course. Will there be some physicians who don't want Medicaid expansion? Of course. This has been an ongoing debate for years, probably will continue to be an ongoing debate for years. There is not an agenda out of this body. This is to make healthcare better in the state of Wyoming. And again, the membership is from people doing the work in the industry, who of course will have opinions. Again, Medicaid expansion has been discussed in the Health Task Force. Has that come forward as a recommendation out of the Health Task Force with those associations sitting on it? No, it has not. So there is not an agenda there around Medicaid expansion. It has to be a conversation in all that we do when we talk about healthcare, because there are people who are covered by Medicaid who are just as important as citizens of Wyoming as those covered by Blue Cross Blue Shield. Their voice has to be heard, but that is not the agenda of this group. And I want to make that very clear.
Thank you. Ms. Klein, welcome. Jump on in, the water's warm.
Good morning, Mr. Chairman, members of the committee. My name is Carrie Klein. I'm the Executive Director for the Wyoming Optometric Association. And with me here, I have Dr. Luke Brogue, and I'll let him offer just a few comments, and then I'll offer one final thought.
Welcome, floor is yours.
Thank you, Mr. Chairman. I practice in Thane, Wyoming as a doctor of optometrist. And I want to thank you for a couple years ago bringing greater access to patients in Wyoming. When Wyoming optometric practice was updated, I'm now practicing to the full extent of my education and can serve my patients daily with all the procedures that they require. As part of the healthcare system of providers in Wyoming, it is important to me that I maintain my education and continue to be able to provide my patients with the care they deserve. As a legislated profession, I feel direct access to you in the future to update or make changes to how I practice is critical. I appreciate that sometimes the issue can be complicated, and I take my part in educating you on any changes seriously. I value the work we did together a couple years ago and believe that creating a system where any legislative profession must go through a committee or authority prior to bringing it to the legislature adds further barriers to ensuring the best care for my patients. I support the potential work and collaboration it took to get to this proposed healthcare authority and what it could provide, but wanted to convey that this should not be used for any Practice Act updates for any profession. Any questions?
Questions for Dr. Brogue, Ms. Klein? Then we'll throw questions to both of you after.
Yeah, just briefly, Mr. Chairman, to conclude, we do applaud the focus on ensuring high quality healthcare and access for patients all across Wyoming, and really appreciate Ms. Davis commenting that they do not envision that Practice Acts will be any part of this healthcare authority. But we did want to take the opportunity to really emphasize that we feel any direction that this group would take in the future to include Practice Acts would just create more barriers. And Mr. Chairman, if I may, if this does move forward, I would also like to offer up a suggestion. When you look at the proposed makeup of the group, it does not include any allied healthcare professional in there. We know that many of these professions do provide significant care in our rural state, and perhaps putting a member on this committee would also further the purpose of bringing all partners to the table. So any questions?
Questions, Ms. Klein, Dr. Brogue? You have one? Senator Bouchard, do you have one? Or is your mic's just on? Okay, thanks. Seeing none. Any other people here to talk about healthcare task force as we move forward? We do have someone who didn't register who apparently would like to talk, so we'll pull them in real quick. Ms. Bieber, if you can hear us, give you a couple minutes to share your thoughts on the Healthcare Authority. Go ahead.
Can you hear me okay?
Yep, we can. Floor is yours.
Perfect. My name is Sarah Bieber. I'm from Casper, Wyoming. I am a registered nurse. Have been for about 10 years, but I've been in the medical field for over 20 years. I have 5 or 6 things that I want to point out about a healthcare authority, and it isn't just the name that is scary. To me, as a healthcare professional, this worries me, and as a mother and a consumer of the healthcare industry, this concerns me. To me, this is government overreach. It's unnecessary for the government to get involved any more than it already is in the healthcare system. It's not necessary. It's not needed. If it was more of a market-driven approach, it would potentially fix a lot of the issues that it has. Bureaucratic insufficiency is a huge issue that we see in multiple areas where bureaucrats run the majority of the show. It's slow to adapt. It struggles with effectively managing, that was pointed out, the complex nature of the healthcare systems. And to me, this could make a one-size-fits-all approach, which is not appropriate in healthcare on any level ever. The diverse needs of patients, of individuals, of communities, of families, especially here in Wyoming and our rural areas, it takes away those people's ability to choose for themselves, which is another major concern that I have. The cost concerns also. What is it going to cost to establish, maintain a healthcare authority? What does that look like for the taxpayers? We're getting hit on multiple sides, and it doesn't look like it's going to calm down anytime soon. As was mentioned, there is one member on the proposed makeup of the board that would be a consumer, that would be somebody that wasn't, I don't know, in the industry. To me, that is an unfair slant, because these people are speaking for people or representing people not by election. To bring issues to our legislature, who are elected officials that do represent us, they need to hear from us, not just people representing portions of us. I think that makeup needs to be potentially different, even if you continue to consider this. It has the potential to impact the private sector. There are independent doctors, direct primary care doctors, that are not represented here today by any of the associations or organizations. There are doctors that are not part of any of these organizations or associations. That impacts them. This healthcare authority could potentially impact them in a negative fashion, and they don't have anybody representing them who gets to speak for them unless they show up. But then that is their public comment, all of those kinds of issues that we see already. And back to the personal freedom, it is still an individual's choice to have healthcare. It's still their choice to not have healthcare. There are factors that impede their ability to get that and to maintain healthcare insurance and all of those things, but it is still their choice. It is their choice to seek medical care, all of those things. Having an authority that governs certain things about that, or how that functions, could impede their freedom to make those choices, which further goes along with a loss of faith in the system, in the process, in healthcare in general, which we have fought with since 2020. I don't know that we've lost complete trust and faith in all of it, but yes, we still have to seek care, but do we trust it like we did? I don't know. There's a lot of people that don't, and that's scary to me, because we still need to take care of people. Those are the main points that I have. I'll stand for questions.
Appreciate it, Ms. Bieber. Questions? Seeing none. Any other testimony on Healthcare Task Force for the time being? All right, well, we'll get you a draft for the next meeting. And we can talk about who should be on it and why they should be on it, and who shouldn't be on it, and pursue down the path, Ms. Davis. Real quickly, I would like to point out former Representative Simpson in the room. And I'm glad he gets to re-experience. But he is a representative from Star Valley before Representative Allred. So we're certainly happy you've joined us today. And I know you have a new position and drove by that magnificent building. I'm very proud of the work you've done here in the community, but we certainly miss you in the legislature. I'm not sure you miss us. We certainly miss you. But thank you for stepping in. With that, music therapist.
Mr. Chairman.
Yes. Representative Hornock.
Thanks, Mr. Chairman. Just a question. Do we need a motion first to move forward with a draft legislation on that task force?
I think Senator Baldwin and I just said we're going to do it. So we're probably just going to go ahead and draft a bill. But if you'd like an official motion. Sure. Let's take a motion. All in favor of drafting some legislation for our next meeting in Pinedale regarding a healthcare task force. Everybody in favor, say aye.
Aye.
Opposed, say no.
No.
That motion's passed.
Mr. Chairman?
Representative Ward. Oh, yep. Let me do a division real fast. Division being called. All those in favor of the motion, please raise your hand. 2, 3, 4, 5, 6, 7, 8. Okay, that motion's passed. Representative Ward.
Thank you, Mr. Chairman. I was going to ask if there's a way to get a recorded vote on this motion.
I was omniscient, and that should be recorded on video for all time. But Ella, so you got that, and if you would put that in the minute notes on Representative Ward's request on who voted in favor of that motion. You need you're good, LSO, on who that was? Okay, one more time, those in favor of the motion, if you raise your hands. Recorded enough? And Representative Barlow. Okay. With that, we won't take a break until after music therapists, and we're super excited to have you because we need some more therapy in the legislature. Mr. Schneider, floor is yours.
Thank you, Mr. Chairman. Just waiting to get our visuals up here on the screen for you. But while we do that, I'll introduce myself. My name is Andrew Schneider, and in my day job, I'm the executive director of the Wyoming Arts Alliance, here today representing the Wyoming Music Therapy Task Force. As we presented to you all in March, the Music Therapy Task Force has been working over the last 2 years. They've engaged all of the board certified music therapists in the state in a conversation about licensure, and as a group decided they wanted to pursue licensure for the profession. We had extensive meetings, first with the governor's task force, which steered us towards the mental health licensure board. We met with them. We incorporated feedback and comments from those groups into some draft language that we've prepared and handed out to you all. So we tried to do our best to prep, and we also listened to your questions in March, and we rolled those questions into the presentation that we have for you today. So I'm going to join as a panelist here on Zoom and then share my screen. And then I will turn it over. Today we have one of the things you asked for is an explanation of what music therapy is. So that's really the primary focus today. We have 2 board certified music therapists with you today. You also asked questions about how licensure is handled in other states. And so we have someone joining us from Zoom, from the National Board of Certification for Music Therapists, who can answer your questions about how other states have handled licensure. And with that, I think we are up and running.
Okay. And it's about a 15-30 minute presentation?
I think we're right around 30 or 35. So
Okay.
we'll talk fast.
Oh, great.
Thank you.
You're welcome.
Okay, good morning, Mr. Chairman, members of the committee, and thank you for this opportunity today. My name's Tom Goycochea, and I have been a board certified music therapist for almost 4 years now. I live and work in Jackson. I'm a self-employed contractor, although I work full-time through the bulk of really just 2 contracts. I work 3 days a week, 9 to 5 at a residential school for emotionally and behaviorally disabled kids. And then 2 other days a week, I work through Teton Music School doing contracts for community outreach. I work weekly at a day home for adults with different disabilities. I work at the high schools in the high school special education department in Jackson. I work weekly with a different residential wilderness treatment program for adolescent boys. And that about covers it. I also have a handful of just private individual contracts. So quite a few different people and populations that I work with.
Thank you, Chairman and committee, for having us here today. So my name is Hillary Camino. I'm a music therapist practicing in Jackson, Wyoming. I've been practicing for the last 11 years, and I'm currently employed as a full-time music therapist at our local hospital, St. John's Health, where I work in long-term care, also acute care settings like our primary care unit, ICU, intensive rehab facility, and oncology. So I provide music therapy services throughout the hospital. Today, I want to talk to you a little bit about creating the task force. I created this task force, the Music Therapy Task Force, 4 years ago in hopes that we could gain state recognition and provide more access to this amazing service throughout Wyoming, not just where we have it currently. And I grew up in Wyoming. I went away to study music therapy and came back. And so these are 2 really important parts of my life intersecting here today. So I really appreciate this opportunity. So before we get into licensure, we're going to talk about music therapy. What is music therapy? So in short, it's difficult to describe music therapy quickly. So we're going to do our best today. But in short, music therapy is an allied health profession that uses evidence-based musical interventions. So everything that we do is all rooted in research to accomplish individualized goals, to improve or maintain social, cognitive, physical, and emotional well-being of individuals. And a music therapist must have a bachelor's degree or higher in music therapy and must be board certified, which is a national certification, in order to practice as a music therapist. So we're going to kind of break down what that means. What does the first part of that sentence mean? How do we use music to accomplish these individualized goals? So we're going to give you some examples today. First off, facilitating emotional processing. So we really practice within these 4 domains, these health domains, and we're going to focus first on emotional processing. And in music therapy, it's really the interaction in music. It's not necessarily me playing music for someone. It's singing together, playing instruments together, writing songs together, and the interaction between the client and the therapist. Even when the client isn't necessarily able to respond musically, let's say they're comatose or that they're end of life or an infant, then we're always responding to their physiological responses. We're watching their heart rate, we're watching their breathing patterns. And so there is an interaction always happening. So emotional processing, I'm going to give you an example of working with hospice. So I spend part of my time working with people at end of life, and using therapeutic songwriting is a really useful way to process emotions. So if you think about when music is introduced into a room, I was going to have you all sing today, but we don't have time, shucks. I'm sure you're all very sad about that. But when music is introduced into a setting that you don't typically have it, like the hospital setting, where it could feel very sterile and clinical, it really changes the atmosphere to feel much more comfortable and approachable and safe. So I'll begin by bringing in a song that this client knows and prefers. Everything, all the music that we play is always client preferred. I don't bring in my favorite songs. It's all about the songs of the people we're working with because it's much more effective and meaningful for them that way. And so let's say this individual really enjoys country western music and really likes John Denver. So I'll bring Country Roads. And I'll ask that individual to sing it with me. And I'll say, you know, this isn't, please don't worry about how this sounds. This isn't about singing well. It's about the enjoyment. It's about the engagement in music together. And so we'll sing that song, and it really helps break down barriers. And we build the therapeutic relationship really quickly that way because it breaks down barriers. It helps the individual connect on a deeper level more quickly because we don't often have that long of a time to see our patients. So from there, I would reflect on the song and say, okay, so did you ever grow up on a country road? Or if you didn't, what was your childhood home like? And we'd go into deeper conversation and I would say, okay, if this road were taking you somewhere after this life, where is that for you? And we can reflect and talk about that. Maybe they need some spiritual support. People at end of life often need help to facilitate closure, to grieve, to accept this phase of life. And so we'll work through that by talking about music, always coming back to music because it makes it less invasive and more approachable. And from there, we'll start collecting lyrics to the song. We'll make a song. I'll say, oh, what kind of music would sound good with these words? Let's try country sound. Okay, what about folk? Maybe it's a combination of the two. Then once the song is done, then I would take that song and record it. And I've been trained in how to record songs using professional recording software. And make this song and then give it to the individual I was just working with, and they can continue their emotional processing and reflect and listen back and think, okay, really digesting everything that we discussed in the session. So there's not only that, but we're able to then give that piece of music to their families as a way for them to say goodbye, as a way for them to have a bit of control back in their lives at a time when you're losing a lot of control over your autonomy and your future. So that's just one example of how we would use music to facilitate emotional processing. I'm going to pass it over to Tom to discuss how he works with his clients.
Yeah, so then I have another example of facilitating emotional processing also in this one, which we'll show you a video after I give a little more explanation. It's sort of also simply improving emotional state for this group of people. This is the group of adults that I work with weekly at the day home for adults with different disabilities. It's called Community Entry Services. And the mission statement at Community Entry Services is to empower people with disabilities to maximize independence and lead satisfying, productive lives in the community. The folks who attend this treatment and training center in Jackson, Wyoming, received weekly group music therapy sessions with the primary goals of improving mood and increasing communication and cohesion among the clients. So another thing that's worth pointing out is that we do look at in terms of these four overarching domains or health goals, but they sort of almost always overlap too. So while this is an example of improving emotional state for people, it's also an example of improving social skills and cognition. It kind of speaks to the sort of the holistic approach of our practice. But the overarching mission of integrating these adults with disabilities into the community in positive and productive ways, many of them participated in a community music recital that included many other members of the community. This video shows that recital and exhibits just how positive the experience was for the clients, how effective it was at including them in the community, and how well received they were by the community. So yeah, we can just check this out for about a minute. One thing that I like is, so the members of the community that aren't CES are generally the people facing away from the camera. And then my clients at CES are most of them facing towards the camera. But it's cool because it was a casual inclusion, which sort of felt like erasing borders already and including everybody. You can also see that most of the clients are playing instruments of some sort, which is fun. And then one of the weekly clients is about to take a harmonica solo, which he loves to do. Yeah, I love that. He loves to play harmonica. We can stop the video there. That's yeah, so it's a neat example of including people in the community. And through working with them weekly, it's also improving their mood, which then compounds to sort of raising their quality of life in general. Okay, I'm going to keep going. Our next example is in the cognitive domain. So this one is from a school that I worked with of emotionally behaviorally disabled kids, where we wrote a song. Let me get my script. It's called the Zones of Regulation song, originally entitled the Dove Color Feeling song, was written by a group of middle school students who are outpatients at a school for behavioral health. The students co-wrote all of the lyrics in a collaborative fashion with the only prompt of let's write a song about feelings. And the lyrics reference Leah Cooper's Zones of Regulation, which is a curriculum that associates different moods and emotions with different colors to help these kind of kids understand and process their feelings and emotions better. So again, while this is an example of improving cognition because it's a cognitive process, it's also an example of helping kids process their emotions. And then the music was composed using GarageBand. So like Hillary said, we're trained to record and produce almost professional level music. And so this is an example of that. The kids wrote all of the lyrics. They gave us the kind of music that it wanted to be, which was electronic and dub style. So you'll get a taste of that. I never got consent to use their identities. So the voices you hear on this is me and the other music therapist I was co-treating with. It's too bad we can't crank it, but oh well.
There's always here that be. Sometimes you're in the rush. Angry, enraged, upregulated, can't control thoughts in my head. You can't always be happy. Sometimes you are yellow. Anxious, shy, hyper, or frustrated, waiting by without a hello, trying hello. And focus happy, don't need to be scared. Oh, in the end, it starts to get a joyous feeling.
That's probably good for that one. So that's a neat little example of using songwriting to facilitate emotional processing and cognitive processes with language.
Okay, and something also to note there, those kids are going to be listening back to that song, right? And so it's like the earworm, this music that gets stuck in our head. So they're listening back to that and they remember those zones of regulation because they know the song. They forget, oh, what's the red zone? Oh yeah, what's the song tells me this. So it's really useful in that way. I also want to mention here with cognition, a very popular example is former Congresswoman Gabby Giffords, who had sustained a gunshot wound, which resulted in severe brain injury. She actually used music therapy to learn how to speak again. And this is because music is held in all different areas of our brain. And so when one area of the brain becomes dysfunctional, you can still access those functional areas where music is held to build new neural pathways. So this is another example of how we work on cognitive goals. I'm going to talk to you a bit about Alzheimer's and dementia and my work with those folks. And also want to mention here that music therapy has been shown to be one of the only interventions that actually improves cognition. It not only maintains cognition, but it improves cognition with people with Alzheimer's. So it can be a really effective treatment for these folks because it's held in that part of the brain that has not been affected by the disease. It is still spared. So as you may have experienced being with someone with memory loss, they may not be able to have a conversation, but they can sing a song. And so this is the way that we reach them. is through music. So when I'm thinking about providing a group for people with memory loss to really target social skills, you think of music as this connecting force. So when you go to a concert or when you're singing in church and you're all singing together, that has a way of uniting us across cultures, across demographics, across languages, because music is that universal language. We don't need to speak the same language to enjoy it together. That is why it works with this population, because when they're no longer verbal, they can still engage in music together. And so I'll have a memory care group where I'll go down and see folks with dementia and Alzheimer's, and we'll often see them during the sundowning phase, which is of the day when they're feeling agitated and anxious. And we'll use music by singing together, playing instruments together to bring their awareness outside of themselves. As you may know, people with dementia tend to go inward and feel isolated, and it's very confusing for them. So we want to bring them outside of that experience and bring awareness to other people in the room. So we'll have them play music together. And as you know, if you've ever played music with someone, it's kind of like having a conversation. I'm listening to what you're doing on the drum, I'm playing it back on the piano, and then we're doing it back and forth. It's this reciprocal communication that's happening. So we facilitate that for these folks to help them feel like they are a part of something. And I will say, I want to add here that it is not only beneficial for the residents who are living with us with a memory loss, but it's also really beneficial for families. I specifically have families come in during music therapy sessions so that they can engage with their loved one and be able to be with them in a meaningful way. And it's also really beneficial for staff. So not only will our staff have their residents be more relaxed going into dinner time and afterward, but the staff will also get to take a break or catch up on charting or do the laundry, do all these tasks that they haven't had time to do because I'm trained and know how to work with people with dementia and lead a group on my own or with one other staff member. So they're able to take a break. Studies have shown that music therapy can eliminate employee fatigue. It can enhance friendship between employees. It can improve work efficiency and employees' sense of corporate identity. And as you know, staff turnover in the Wyoming medical system is an ongoing battle. So if we have music therapists represented in these settings, we can help to combat these issues. All right, I'm going to move on to how we use music to improve motor function and movement. So I have a Parkinson's group where we have people with Parkinson's come and work with us. All of the people pictured in these videos have given consent. Many studies have been done to show the efficacy of using rhythm and movement for people with Parkinson's. Since movement and sound are so closely related in the brain, when you synchronize movement with the sound, you actually see a greater success in maintaining or improving motor functionality. So this is an example, this first video of that group where I just want to give you a little bit of background. I'm working in a co-treatment setting. Music therapists often work as a part of the interdisciplinary team. We work with physical therapists, occupational therapists, speech therapists. Here I'm working with physical therapists so they can provide the physical support while I provide the music intervention. And these are Parkinson's folks. So with Parkinson's, you tend to shrink inward, have smaller movements, a shuffled gait. So what we're really working on are these big movement patterns and reaching out to the drums, and music really having the instruments there really motivates them and inspires them to do this. And we've seen a higher number of repetitions with music being added to the intervention than without. Okay, so that's just a quick glimpse at that group. I also want to give you a short little explanation of how I'd work with somebody on mobility goals. Again, I'm working with an occupational therapist to provide the physical support, and we're using one of this resident's. We call them residents because they live with us. This resident's favorite song, which is Jolene, and I changed the words so that she has this consistent cue to remind her what she's doing, what she's working on. And what I'm singing is big step, stomp on the red line. And the red line is this line that's coming down from her walker where she needs to be stopping to. And if you'll see here, you'll see that she is stepping in time. And that's because with Parkinson's, it's really useful to have that auditory cue where you're driven by the beat. So here's this example. So those are just a few examples of how music therapists work. We could sit here all day and talk to you about how different ways that we work and the many populations that we work with, but we only have so much time. So we're going to move on to the settings, the places where we work. So currently in Wyoming, we have 11 board certified music therapists who see an average of collectively 400 patients a week with 130 hours of face-to-face time a week. And we work currently in places like nursing homes, assisted living, hospitals, mental health facilities, early intervention, hospice, adult daycare, rehabilitation facilities, schools, state county facilities, substance abuse facilities, and some music therapists offer private practice. We also see a lot of room for growth. We currently do not have music therapists representing VAs. We could see growth in representation at the university level, correctional facilities, domestic violence and women's shelters, group homes, residential hospitals, and community senior centers. We do currently have music therapists working in 2 hospitals over the state. That's in Casper and in Jackson. We see growth happening in all of the other hospitals that don't currently have music therapy services. Okay. So within these settings, we work with many different populations. Here are just a few examples of the people we work with. And while we go through these different populations, we want to talk about why it's so important that we are trained in doing what we do when working with these populations, because these are vulnerable populations who aren't typically able to advocate for themselves. Therefore, it is very important that we are held to standards of practice and ethics and continued education as we are as credentialed professionals. So I'm going to let Tom describe the first few.
Yeah, I'll cover the first 4 on the left side and also talk about, as Hillary was saying, so with vulnerable populations, we're trained to limit the possibility for harm in all kinds of ways, whereas somebody who isn't trained in music therapy and maybe an awesome musician wouldn't have the sensitivity or the vigilance that we're trained to have to limit potentials for harm. So first example are people with autism spectrum disorder. At the school I work for and occasionally in private practice, I've worked with different kids with autism spectrum disorder. Some of the common goals for music therapy treatment and for speech language pathologists or occupational therapists, a lot of the goals for autism spectrum disorder kids revolve around communication skills and social skills. But what I need to be aware of is that another common manifestation of kids with autism spectrum disorder is having hypersensitivity. All their senses tend to be raised, and since I deal with sound and music, I have to be super aware of the volume. It's called hyperacusis with people who are maybe extra sensitive to loud noises or sounds that they can't predict. So I have to start at a soft volume. I have to make sure they're ready and not like play the guitar when their backs are turned or things like that, or otherwise I'll lose them I'll lose the therapeutic effectiveness and maybe even escalate a kid where they might become violent or leave and not want to work with me ever again. Okay, developmental disabilities. Autism spectrum disorder is a developmental disability. I work with kids who have numerous other developmental disabilities. My little example for this one is these days, currently I'm working with a little guy who has Prader-Willi syndrome, which is a genetic disorder that affects him in numerous ways. It's just developmental disability in a variety of ways. But one thing I have to be extra sensitive to is he has a pathological eating disorder called pica, in which he's sort of always waiting for anything that he can eat, including non-food items. So if I wasn't aware of that and gave him like a guitar pick, it could very well end up in his stomach. So I have to be aware of that and not give him like small instruments or things that he could put in his mouth. Mental illness, another example I have. I don't work with this girl anymore. She discharged maybe 6 or 7 months ago. At the school, I worked with this teenage girl who had a different genetic disability, and one of the manifestations for her was that she had auditory hallucinations. She would hear voices. And the way I limited the potential for harm there. I never got in the weeds about trying to discuss with her whether or not the voices were real or how she could maybe try and learn to just ignore them, because that would invalidate her experience. And again, I'd probably lose any therapeutic effectiveness and or maybe emotionally escalate her. Instead, I worked on a sort of behavioral technique with music therapy in which we tried to replace the auditory hallucinations with internal singing. So she loved to sing, and I started to teach her how to sing in her head, because that uses the same auditory cortex processes as what happens with people with auditory hallucinations. So that was an effective treatment, because internal singing helps to just replace the voices, and instead I didn't have to worry about trying to worry with her whether or not they were real or not. Last example for me, people with post-traumatic stress disorder. So at the school where I work, a large percentage, probably at any given time, at least 70% of the kids that I work with are diagnosed with PTSD because they experienced pretty severe neglect and or abuse growing up. And with this one, there's kind of a lot to talk about. To try and be short with it, music inherently calms the nervous system if it's calming music, if it's the client's preferred music, and if it's sung, it operates different polyvagal nervous system things that put us away from the fight or flight mode. So you're in your calm state where you can feel safe and you can begin to access the higher levels of thinking that's important for these kids to be able to process their emotions and everything. On the flip side of that, there also prolonged stress, PTSD sort of physically reorganizes the nervous system. And so if my training didn't make me aware of that, I might try and engage with these kids the way I would with the typical person, which could accidentally trigger them. Or if I even just try to push a kid to interact or engage the way I would with the typical person, I could, there's like a spectrum of how it could cause harm. Well, let's start with a bigger example is I could just escalate them to the point of a violent incident through not being sensitive to their needs. Or the other side of that would be that I would just lose the relationship if I tried to push them to engage or whatever and didn't give them the opportunity to say no. I wouldn't be building the trust and the attachment security that they need to help start to feel better. I'd lose the therapeutic value, and then that would turn into a longitudinal problem because PTSD is an overarching disorder over time. And so if we lose our effectiveness, they're very likely going to need a higher level of care down the road, which turns into bigger costs as well, which is something that we'll talk about because the potential is for them to end up in a higher level of care, like a psychiatric residential treatment center or incarcerated, is pretty high. So those are ways that I mitigate the potential for harm of working with these different populations.
So working with music therapy when working with premature infants can be incredibly effective and useful. I'm just going to breeze through this. So when you're working with this very vulnerable population, it is highly important that you are trained and know how to play music and how to provide music therapy to these individuals. I already talked about Parkinson's, terminal illness, and Alzheimer's to you before, and we'll just keep moving forward so we can get through this with you today.
Okay, I'm going to briefly address how music therapy has been shown to be a cost-saving intervention. 3 little points. It can reduce the number of sedatives and pain medications used. It can shorten hospital stays, and it can reduce incidents of violence. So going back to the example I was just giving earlier, in terms of reducing incidents of violence, a lot of the kids that I work with can be quite volatile. But also for a lot of them, music is powerful enough for them. It's inherently motivating that a lot of what I work with them on is learning how to use music to calm themselves down and not escalate to the point of blowing out. And so like one guy that I'm currently working with, he's recently identified that a super powerful coping skill for him is to sing to himself the lyrics of Lost Boy. And if he can remember to do that, or somebody can prompt him to do that, if you notice that he's becoming agitated or escalated, if you catch him early, the blowout that might happen doesn't happen because he's calmed himself down through singing. Yeah, let's go over to sedatives and pain medications. Oh, I have one quick research article I want to quote with this one. Just page on my laptop. So this is from a meta-analysis in our Journal of Music Therapy, which came out. This is from 2016, but the results state that analysis of the 97 included studies revealed that music interventions had statistically significant effects in decreasing pain on a 0 to 10 pain scales, other pain scales, emotional distress from pain, anesthetic use, opioid intake, non-opioid intake, heart rate, systolic blood pressure, diastolic blood pressure, and respiration rate. So it was effective in treating all of those vital different signs of people in being hospitals. So it is effective to reduce sedatives and pain medications. And then a little, my little personal anecdote about that is I did my my training, my hospital training I did at Primary Children's Hospital in Salt Lake City on my internship. And I assisted with what they call PICC line transfers a few times, which is where you take the IV out and to put a new one in when kids need it. And that I think is maybe marginally painful, but it caused anxiety and nervousness for the kids because there's needles involved and they didn't like it. So the kids' parents were within their rights to ask for mild sedatives or painkillers. But often they would just call the music therapists in to sing a couple of the kids' favorite songs with them, which just distracted from the operation, and then sedatives weren't needed. Okay, and then our shortened hospital stay, I have one more video to show you also. So the music therapist you'll see in this video was my supervisor, and this is her work with an oncology patient. Maybe we'll play the video first, and then I'll give you a brief little explanation.
Take it with me if I here we go. I've been dreaming of this since a child. No, it's hard when you're feeling down and it's the long way.
Maybe for time we can stop it there, but the important little clip in that is what she's doing again. She's using musical prompts to cue his speaking ability, because this is when he was just regaining the ability to speak. Let me read the little, so Isaac was diagnosed with leukemia after a hemorrhage in October of 2018. He was referred to music therapy while he was in the ICU for family support, as they thought he might be heading towards end of life. Music therapy played his favorite music at his bedside while he was non-responsive, and his family sat at his side holding his hand, singing along, and providing positive encouragement. Isaac slowly began to recover and moved to the neurotrauma unit so he could begin therapies to regain his functioning. His first words after his hemorrhage were the lyrics to Leonard Cohen's Hallelujah, and music therapy began co-treating with speech therapy using music and singing to help him continue to relearn to talk. So this video is shortly after his first words, and the treatment helped him regain other functioning as well, which shortened his hospital stay.
So we did put together a video that we're not going to share today. We'll just skip over it. But
We'll provide this video to you. It's about 5 minutes, and
Yeah.
we know that we started late, and so we'll try and help you catch up here.
yeah, just so you know, that Tom and I are representing the task force today just because we live close by, but we have many other music therapists throughout the state who were a part of this video. So we put this together to show the things that are happening throughout Wyoming with music therapy. And in the draft language, the scope is clearly defined. So we can get to that later once we're going through the draft language. Just know that music therapists are held accountable to practice within their scope. We understand the limitations of our scope, and we often use music therapy as a treatment model with other therapies, so as a supportive system to other therapies. We've seen music therapy grow in Wyoming in the past 10 years. So you can see in the gold counties, that's where we currently have music therapy, and in the white is where there's so much room for growth. And that is why licensure will really be wonderful so that we can offer music therapy services to these areas that aren't currently represented. In the last 10 years, the number of music therapists has almost tripled. So from 4 or 10 years ago to now we have 11, and we foresee that continuing to grow, especially if we have licensure, so that we could have these counties that aren't currently represented have music therapists practicing there. So in conclusion, we've talked a bit about the importance of licensure, but just want to cover a couple of other things with you today. In programs with state oversight, such as special education, early intervention, aging, and disability services, regulations often require an official form of state regulation of a credential in order for them to support professional services. So once Wyoming has licensure in those programs, licensure for music therapists, in those programs with state oversight, your consumers will have more access because it will be a professional service that's provided and seen as a professional service, which will then create more music therapy jobs. And I just want to mention here, I am approached often by students studying at the University of Wyoming, really interested in the field, wanting to go away to get their degree and come back and live in Wyoming. And we want to have that opportunity for them to live here and practice as music therapists. And licensure will help this profession grow and create more jobs. And we already talked to you a bit about ensuring safe practices and decreasing potential harm.
So now is when we'd like to bring in our certification board person on Zoom, please. And she could talk to you. This chart shows you where state recognition of music therapy exists. This is as of September 2023. The dark green is where music therapy is recognized. The striped green is where draft legislation is being proposed, and you'll see Wyoming is there. And then you will also see the light green where there is currently 2024 legislation moving. So that kind of implies a little bit of a trend there as task forces like Wyoming's task force get together. And Kimberly, I'll turn it over to you.
Welcome, Kimberly. Floor is yours.
Thank you so much. I appreciate having the opportunity to testify virtually as I physically reside in the state of Florida. So good morning to all of you in Wyoming. My name is Dr. Kimberly Senna-Moore. I'm a board certified music therapist, and I'm also Regulatory Affairs Associate for the Certification Board for Music Therapists. This is the organization that issues the Music Therapist Board Certified or MTBC credential to individuals who meet requisite education and clinical training requirements. Through my role with CBMT, I've been working with the Wyoming Music Therapy Task Force on seeking the creation of a music therapy license in the state. I am not alone in terms of this national support. I do this in collaboration with a colleague through CBMT, Dr. Dina Register, and a colleague with the American Music Therapy Association, Judy Simpson. The efforts of the Wyoming Music Therapy Task Force are part of a national movement supported again by both AMTA and CBMT to help increase access to safe and competent clinical music therapy services that are provided by trained and qualified professionals. And to date, this has led, as you can see in this quite helpful map that Andrew has pulled up, this has led to the creation of a music therapy license in 13 states. There are an additional 4 states that have another form of state recognition or occupational regulation, everything from a state certification to a registry to title protection. But in most of the green states, there is a music therapy license in those states. I do want to underscore this element of providing safe and competent music therapy services as they're critical. Music therapists have the requisite training and skill set to be aware of and responsive to safety considerations when engaging individuals in music-based interventions. And you heard some really nice examples of how this might look from Hillary and Tom just a little bit ago. And so for these reasons, my colleagues and I, we support Hillary and Tom and all the local music therapists in seeking licensure for music therapy in Wyoming. And we do strongly encourage you to please advance this proposal as a committee bill during the upcoming regular session. I'm happy to answer any questions you have about some of the activity happening across the United States. Thank you.
Thank you, Ms. Moore. Would I be correct in the other states in dark green on this map? To be state licensed, they also have to be licensed by the national organization? Or can any of them just hold a state licensure for music therapy without recognition from your organization at the national level?
So the eligibility requirement for any sort of state issued credential is holding the MTBC. And that's actually, we found that to be of benefit to the state because we have these national standards and national education and clinical training requirements well established. It's actually saved states time and money in terms, they basically don't have to create it themselves. So the proposal we set forth utilizes kind of our existing infrastructure as a way, again, to ease the administrative burden and financial burden to the state.
And just
yep, go ahead,
Mr. Chairman. So certification happens at the national level. There is no provision for national licensure. It's up to the states. It's a state's issue.
Absolutely. Yes.
Questions for Ms. Moore while I have her. Senator Hutchins.
Thank you, Mr. Chair. Just to get this right, the national board, you said something really quickly at the end that kind of perked my interest, because I'm kind of wondering, where did you come from? Where did this board just develop when you say nationally? What happened to make this a national board? And then you have the ability to certify people in the states. If you can answer that, either you or the woman on the small woman in the box, because I can't see her. I wish she would lower up a little bit so we can see her, or is that not possible?
Mr. Snyder, do you want that or turn it over to Ms. Moore?
I will let Dr. Moore take that.
Dr. Moore, go ahead.
Thank you so much. And just to be very difficult, my last name's Senamore, so it's Dr. Senamore, just so I would get to explain that for the rest of my life. I appreciate the question. And so I think it's important to clarify the difference between board certification and state level occupational regulation, which is what a license is. So I work for the Certification Board for Music Therapists. This organization has been around since 1983, and its primary purpose is to issue the MTBC, or Music Therapist Board Certified Credential. This credential serves as a measure of quality assurance to employers, state agencies, etc., that an individual who holds this national board certification has met and has demonstrated competence in what it means to be a music therapist. There are other medical professionals who have national board certifications that also, say, hold a license in a state. You see this, for example, with medical doctors who will be licensed to practice in their state, but may hold a national board certification in some sort of specialty area that is specific to demonstrating competence in that area. So in the music therapy profession, the board certification actually came first. And through kind of shifts in industry preference, if you will, that started to come out in the 1990s, it was kind of state governments that started to recognize and would support service providers who are licensed in those states. In recognizing this, in about the mid-2000s, our two national organizations came together to see how we could support improving consumer access to safe and competent services. And so that led to this initiative, of which Wyoming is a part, to get the profession and the credential recognized at the state level. And so it's in the state of Wyoming, we're looking to create a license. You heard Andrew earlier say this is based on multiple conversations, both within the music therapy community in the state and outside of, to see what is the best fit option in Wyoming. So I hope that helps clarify kind of the difference between board certification and state level occupational regulation.
Representative Clouston.
Thank you, Mr. Chair. Dr. Sina Moore, what are the requirements to become nationally certified as far as education, testing, internships, that kind of thing?
Yep.
Ms. Sina Moore, Dr. Sina Moore.
Yes, happy to answer that. And so all music therapists must complete education and clinical training requirements at an educational program that is approved by the American Music Therapy Association. And the curriculum and training of a music therapist includes coursework in music. So there's a primary instrument. They take lessons. They take music theory and music history. There's classes a lot in the psychology and the sciences. Sometimes it's human development or it's statistics. And it's music therapy classes, which include not only learning about the music therapy treatment process, but actual hands-on field experience. The last bit of the field experience in an educational program is an internship. And this is a 6-month full-time clinical training internship that students complete as part of the degree requirements. Once an individual has completed all the coursework and the clinical training, they're eligible for the board certification exam. And the board certification exam is developed through a rather rigorous industry standard process by CBMT, by the Certification Board for Music Therapists. And it meets certain psychometric qualities that ensure the test kind of reflects current practice in music therapy. Once an individual has successfully passed the National Board Certification Exam, then they're issued the MTBC credential. So it's a little bit of both. It's the education clinical training. All music therapists hold at least a bachelor's degree in music therapy. Once that's finished, they're eligible for the exam, but they only receive the MTBC credential once they successfully pass the exam.
Okay, further questions for Dr. Sina Moore? Representative Ward, go ahead.
Thank you, Mr. Chairman. I'm not sure if we want to hold our discussion on the bill draft until we get to that, but I have a question about the penalty. Do you want me to hold my question?
Yeah, if you would.
Yeah.
I don't think Dr. Sina Moore is gonna have that one. Anybody else for the doctor? Go ahead, Representative Warnock.
Thank you, Mr. Chairman. You mentioned testing requirements, could you explain what the testing requirements are, what the test is like?
Yes,
Doctor?
it is. I'm happy to. Thank you for the question. This is a 150 item test. It's all multiple choice. And it addresses items or issues that are outlined in the board certification domains. So I mentioned earlier how CBMT kind of follows industry best practice in terms of credentialing. So every 5 years, the organization undergoes a practice analysis. They survey music therapists across the country, and from that, it generates different areas that music therapists do, so to speak, as part of their practice, from assessment to safety, to treatment planning, to professional responsibilities, treatment evaluation, etc. The end result of this practice analysis process is a whole list. It's a 4-page list organized by 4 or 5 different areas that lists all the skills and tasks a board certified music therapist might be trained to do or able to do that is within their scope of practice. We call this document board certification domains, and I'm happy to share a copy with you. It's freely available on the CBMT website. The board certification exam, all the items on the exam are based on the board certification domains so that the test items reflect music therapy practice. There's a certain pass rate. The pass rate is also adjusted about every 5 years, but it is generally around anywhere from 70 to 75%, where if somebody has successfully answered at least 70 to 75% of the test items, they pass the exam. And again, that number and the way of calculating that number does follow credentialing practice.
Okay. Seeing no further questions, certainly. Oh, you do have another one. Senator Hutchins, go ahead.
Thank you, Mr. Chair. Mrs. Sinnemore, question on other professions that may use music as a form of therapy. If you know of any, thank you.
If you know of any.
I do, and thank you. I appreciate the question, and this is one we get a lot because there are counselors who maybe use songs and play CDs as part of their work with patients, or there's nurses who come in and sing to their patients in a medical facility. It is not our aim to limit the use of music. Music is this really wonderful, beautiful thing that can be quite helpful and useful. The way, though, that music therapists utilize music is oftentimes we're using live music, and it's our professional training as musicians and our ability to develop, implement, adapt, and create these experiences where clients can be successful, where they're engaged in writing music, where they're engaged in improvising music, they're singing with us, they're playing with us. And we do this in a way, we structure these experiences to have a really specific therapeutic focus. It's that level of musicianship that makes what we do different. The template bill language that we use includes exemption language to allow other professionals to use music if it's within their scope of practice. But certainly how we as music therapists utilize music is much deeper and much broader and much more expansive and effective because, again, of that specific musical training.
Okay, your follow-up? Go ahead.
Based on what I'm hearing, the musical therapists are already operating here in Wyoming.
Mm-hmm.
And the goal, if I have it right, is more to just expand what they're doing and kind of affirmation in what they're doing. So I'm wondering if they've already gotten into hospitals, nursing homes, what is the difference? What will a license do to help them get into like the VA and the other places that they're seeking to get into? You
And
can
that,
answer that question.
you're welcome to, Dr. Seymour, but we can certainly ask the people here in
Right.
Wyoming,
Roger that.
unless you have some experience on what that's utilized in other states.
I do have experience in other states, and it may be useful to also hear from the Wyoming music therapist if that's allowed. In terms of
Sure,
other.
we'll pass that question on to. Oh, go ahead.
Okay, thank you. I appreciate that. In other states with the license, the impact of having the license has led to several benefits. Sometimes I'll give an example in the state of Nevada. Nevada was one of the first states to have a music therapy license. Similar to Wyoming, there were not many music therapists working in Nevada at the time, but they were working and making a living. There was one music therapist who through actually one of the mental health agencies was able to provide therapy services to individuals with different mental health challenges. And as soon as the license came through, her agency Contact was able to draw from a different pot of state funds that was less limiting than what they had previously used to support music therapy services. And so that right there, through having the license, the ability to expand music therapy in the state of Nevada in this one area of practice changed practically overnight. And so this music therapist and their business were able to provide services to a lot more individuals than they could previously before the license was put into place. As a general rule, it makes it easier for state agencies to know that music therapy is an option. It makes it easier for us to be included as service providers. And it also provides a mechanism for employers and facilities to more easily identify not only what music therapy is, but who is qualified to provide music therapy. So having the kind of definition of music therapy, the scope of practice, the eligibility requirements codified in state statute, we have seen a direct benefit to increased access to services in states with a license. And so that's kind of the general national picture that I'd like to provide.
Representative Yen, follow up.
Mr. Chairman, thank you, and Dr. Seymour. So I think, and maybe you can help me understand if this is true. One of the requirements in the chapter that's being suggested for us for the mental health professions is that you have to basically have no felony or misdemeanors that would adversely affect the type of folks that you're working with and the type of care that you're giving. Do you think that's a good reason also to have licensure to ensure that we have trust that licensed professionals are working with, especially these very vulnerable adults?
Yes, absolutely. I appreciate you noting that. And I think that trust piece is very important. And that can come across in the example that you gave and in other ways as well, to ensure that when somebody's receiving music therapy, whether they're in the hospital, whether they're in an early intervention center, hospice and end-of-life care, there are veterans that they're getting quality services from trained professionals, that they can trust that process.
All right. Well, Representative Ward.
Thank you, Mr. Chairman. So as a doula, I've used music extensively to help my clients. I've sung with them during labor so that it relieves pain. How does that fall into that's one question. When my dad died back in August, we played his favorite music so that he could hear it as he was passing. I'm curious how that would fall under here. I had a kindergarten teacher who would sing, January, February, March, and April, the days of the month to the kids, because that's how they would learn that stuff. So how does that use of music not count as music therapy?
Dr. Seymour, you want to delve into those?
Absolutely. First of all, it sounds like some beautiful work that you do and some beautiful memories that you have. So I appreciate you sharing that. A music therapist, even if we're working with a group, what we develop and implement has a specific therapeutic purpose, and it's based on a documented assessment process. Additionally, we continually evaluate outcomes and document those as well. Music therapy services are commonly included as part of a treatment team, whether it's in a special education session, an early intervention, a medical type of facility, hospice, or an end-of-life care. So we're involved in a different way in actual therapeutic treatment planning as well. All the examples that you gave do fit under the exemption language that we have in bills, because as I said earlier, music can be useful for learning, like the days of the week. It can create these beautiful memories like you provided with, or the example you gave with your father, I believe it was, or what you do to help kind of distract a woman who's giving birth, and to kind of hold that space. So all of those examples would fall under the exemption language we have in the bill. But again, I think it's a little bit of the treatment process and kind of the professional documentation and the assessment, as well as, if there's a situation where music is being implemented and we're continually monitoring for client responses. This goes a little bit to the harm piece. And we have the musical skill set to adapt what we're doing. If we're noticing that maybe a client in a group is starting to get agitated, or they seem to be getting dysregulated, or there's some sort of traumatic memory that emerges. This has happened. We've heard stories of, not in Wyoming specifically to my knowledge, but I've heard stories of, say, volunteer musicians going into a memory care unit. So they're going to play music, with older adults who have dementia as a way to entertain. And there was this one situation where a gentleman was getting agitated, and the musician who was going and playing these songs didn't recognize it and didn't know to recognize it. And this gentleman ended up, he was so agitated, he started to walk out of the room and then fell and sustained some injuries on his leg. It caused some emotional disturbance in him. His family was upset. It cost extra money. And so if that were a music therapist, we would have noticed that we have the training to be aware of and then to respond as needed in the moment based on the different reactions that we're seeing to the music and the musical experience.
Mr. Schneider.
And just to tag on to the end of that, so the example that you gave in the classroom setting, we call that arts integration. And so you'll see that in an educational capacity. So there's sort of straight ahead music education, learning how to make music, and then there's music integration into classrooms. And those are exempted out of the language here.
Any more questions for Dr. Sina Moore? Okay. Are we good? I think we'll get you off the hot seat, Doctor. Thank you for being with us today. Certainly appreciate your time. And we're going to throw some more questions and Ms. Camino and Mr. Schneider here.
Don't go far.
Just in case. But we'll probably turn your camera off for you here. Representative Penn has a question, I think, for Mr. Schneider.
Thank you, Mr. Chairman. So it was mentioned the exemptions that are listed in here. It looks to me by reading that if someone was already, say, an LCSW or something like that and using music in their therapy, it looks to me like they would have to then get an additional license in order to continue doing their music. Is that right? Because it says if you're a therapist, an actual therapist, then that is not an exemption from this.
So
go ahead.
Yep, there certainly are examples of therapists who go above and beyond to get the music credentialing as well. In terms of where that is or is it exempt, I think there's great value for therapists to get that certification. In terms of them being at odds with this language, I'm not sure that I would necessarily agree that they would need to go through there if they're using it outside of the scope of what certification covers. Does that make sense?
Okay, let me see if there's any other public, is it? Sure, question. Go ahead, Senator Bouchard.
Thank you, Mr. Chairman. So I used to volunteer in a state hospital and there were developmental specialists and they were doing music therapy long before it was a thing. So that said, there's other professionals that probably use music therapy that aren't licensed in it currently. And so I'm worried that we carve them out or fence them out. So unless this bill has specific language to allow a psychiatrist, I mean, if you look at the history of music therapy, it was psychiatrists that actually developed it. So that said, I wouldn't want to fence out a psychiatrist that is doing that. So that what I see in the language is it would fence them out. So unless this bill has specific language that allows other mental health professionals to, because I mean, even though they didn't go to school for it, or even though they didn't go to or get their certification, they're practicing medicine just like other professionals do. And so that's my view. Any insight on how we get around this and not fence people out?
Mr. Snyder.
Yeah, certainly, Mr. Chairman, and thank you for the question, Senator. We've worked for 2 years to prepare this language. We've looked at the language in other states. I'm not sure that we've seen in other states an example of what you have described of fencing them out coming to pass. But certainly we would appreciate if you all move this to a formal draft and have LSO take that up, then the opportunity to insert that language to ensure that that becomes an option you would have.
Mr. Chairman, could we bring Ms. Simoneo up to talk about how the exemption language works on the existing mental, because it's existing exemption language, how it works with existing mental health professionals?
I think as she's making her way forward, we do probably have some other public comment in the room. So if one of you wants to stay up, or even two of you, we'll try to open a couple more chairs. And sure, we do have a lunch date here in about 15 minutes. We can be late too, but welcome, Ms. Simoneau. If you remember Representative Yun's question and would try to answer it, and introduce yourself.
Mr. Chair. Mr. Chairman, Lindsay Simoneau with the Wyoming Counseling Association. Can I ask for the exact place where the exception language is that we are discussing?
We can certainly get, yeah, if you know off the top of your head.
Backside of the second page, under
Yeah.
all the red.
Thank
Mr.
you.
Chairman, it's page 4, 33, 38, 103 exemptions. It basically just adds professional music therapists, but I was curious on, because this bill is enacted now without the new language, but it's like, for example, if another health professional was implementing some sort of therapeutic services that could fall under the scope of practice of a different mental health professional, how does that conflict happen? Or is there any conflict, or does it fall under the exemption language that we currently have?
Mr. Chairman, I will say that at this time, I'm probably not going to be able to fully answer that. But what I can say is that any master's level clinician is also trained similarly in what has been spoken to today with music therapists, as far as watching the regulation within the client, watching the responses within the nervous system to the different therapies within the room. A master's level mental health clinician would be able to prevent harm as far as assessing what is happening to the client in real time.
Senator Hutchins.
Yes, sir. I'm gonna try to number these pages so I can get her to the right page. And 9, 10, 11, 12.
Whoa, Senator Hutchins, look, anybody else?
14. I got it.
I just have to
14.
double check real quick. How many other people in the room want to testify on this? Okay, go ahead, Senator Hutchins, a question to Ms. Simoneau.
Okay, page 14, we have up top there, it's kind of in bold, 33, 38, 101. prohibited acts and penalties. I don't know if that's what everybody else is talking about. It says no person shall engage in the practice of professional, and then we go into music therapy unless licensed or certified to practice. So again, with the other professionals, or what if I came in and started singing and playing a CD or harmonica, would I be in violation?
Ms. Seminole, go ahead.
Mr. Chairman, Senator Hutchings, the way that we as licensed professional counselors interpret the prohibited acts and penalties is really making sure that there's no bad actors who are pretending to be a mental health professional when it comes to providing services. If, for example, what I would say is if you are a lay person offering peer support, we wouldn't immediately come in and say that that is, you know, clinical mental health services. How dare you? If somebody is playing a CD or playing music, I would assume that's going to be interpreted the same way. It's going to be somebody who markets themselves as a licensed professional music therapist, similarly to somebody pretending to be a licensed professional counselor.
And then tries to bill for it, I would assume as well.
Correct.
Okay. Ms. Camino, any additional?
Yes, thank you. Also to add to that, so there's a spectrum. There are people offering music in the community for community members, and then in between, and then we have music therapists practicing at a clinical level. So all of those practitioners have a place. It's very important that we're all practicing, but just staying within our scope. And I know that I can work with vulnerable populations because I'm trained in how to do so, but we just want to make sure that people aren't even just to be educated. Some people don't even know that they're not necessarily a music therapist because we don't have the kind of education needed for people out there. So this will provide education for folks to know that they are not in fact a music therapist, and you need to be trained to call yourself a music therapist and to work with these vulnerable populations. You can of course have music in other settings and other therapies. It's just not music therapy. Right? It's not certified profession.
No different than a peer counselor or a social worker, and then all the way up to a licensed professional. Yep.
Yes.
Let me bring in Kelly Buckingham has a hand raised, so we'll bring them into the room here. And Kelly, the floor is yours. Go ahead.
Thank you. Good morning, Mr. Chairman and members of the committee. My name is Kelly Buckingham, and I serve as the chair of the Wyoming Mental Health Professions Licensing Board. Myself and the board commend and applaud the Music Therapist Initiative in pursuing professional licensing standards. I must admit that I did not anticipate this legislation to progress to the agenda at this stage. While the licensing board did hear a presentation in October, it is evident that more collaboration and time are needed to ensure the effective functioning of the proposed structure and to clarify the scope and definitions outlined within this legislation. Additionally, the board feels that the licensing of music therapists better aligns with that of occupational or speech therapy boards rather than mental health boards, similarly to states like Oklahoma, North Dakota, and Maryland. Music therapy licensing, we feel, is better aligned with OT and speech due to their shared focus on functionality and holistic approaches to interventions, that they emphasize multimodal interventions that incorporate sensory, motor, language pathology due to their shared, and their communicative components, which are compatible with the diverse techniques utilized in music therapy. And music therapy often involves nonverbal communication strategies such as music making and creative expression, which complement the communication goals addressed in speech and the holistic approach of OT. Nonetheless, this development underscores the importance of our ongoing collaboration and the necessity for closer communication with the individuals responsible for bringing forth this legislation. The Mental Health Licensing Board operates as a composite board, grouping professions with similar licensing requirements. Yet there are significant discrepancies in licensing prerequisites and educational backgrounds between music therapists and those in the mental health field eligible for independent practice. For instance, industry standards dictate that individuals with a bachelor's degree are not eligible for independent practice to safeguard the public. They must work under the supervision of somebody holding a master's degree, as the latter has undergone more extensive education and supervision focused on mental health practice. Moreover, individuals eligible for independent practice must fill 3,000 hours in provisional status post-graduation. This requirement is crucial for new licensees, typically recent graduates, to receive guidance from experienced practitioners, ensuring adherence to professional and ethical standards, continuous knowledge development, and self-care practices to prevent burnout. Regrettably, this essential aspect is absent from the proposed legislation. Another point of contention revolves around the provision of psychotherapy. As per our current understanding and description in the law, psychotherapy entails various treatments, diagnoses, assessments, and counseling aimed at aiding individuals or groups in alleviating mental disorders, understanding motivations, resolving emotional conflicts, or modifying behaviors hindering effective functioning. The current draft suggests that with supervision from a licensed therapist holding a master's degree, music therapists can provide psychotherapy. However, this allowance conflicts with standards upheld by other professions overseen by our board. In essence, while we acknowledge the value of music therapy and support efforts to establish clear licensing standards, it's imperative to ensure that any legislation aligns with existing regulatory frameworks, upholds professional standards, and prioritizes public safety. We respectfully request the committee consider a temporary pause in advancing this current legislation proposal. This pause would allow both parties involved to engage in further dialogue and collaboration, aiming to better align our respective goals and address the conditions and concerns raised. Such a pause would allow for a more thorough examination of the proposed legislation and its potential implications. It would provide an avenue for meaningful discussion between music therapists and mental health professionals on the licensing board, and foster mutual understanding and pave the way for a more harmonious resolution. We believe that taking this step is essential to ensuring that any future decision regarding music therapy licensures are well-informed, equitable, and in the best interest of all stakeholders involved. Thank you for considering this request, and we look forward to the opportunity to continue working together toward a solution that upholds the highest standards of professionalism, promotes public safety, and supports the valuable contributions of music therapists. I will stand for any questions.
Thank you, Ms. Buckingham. And again, we probably do have 3 meetings, and so the hope would be to get to a great landing spot that works for everyone. And I guess my only major question is, I know they've been working on this for a couple of years. Do you think in the next 4 or 5 months with further discussions, we can get to that place by, let's say, August, whether that's in mental health or occupational therapy or somewhere with more discussions? Can we land the plane by August, in your opinion?
Mr. Chairman, yes, I believe we could. I feel like we're very close to the finish line, and we want to support the advances of music therapy.
Appreciate it. Any questions for Ms. Buckingham? Seeing none, thank you for being here, Kelly. And again,
Thank
we're
you.
just really working on a bill draft, and then I think we can talk specifics at our next meeting. But I should ask, have you considered, should it be in occupational therapy? Should it be in mental health? I know you've kind of worked on this for a couple of years. Quick overview.
Yes, we have explored all of the options for existing boards. We've explored options for new boards. We've explored options even for there was one proposal to have Natrona County Health Department doing this at one point on behalf of the state. So, but through our conversations with the Governor's Health Task Force, we were really led to the Mental Health Licensure Board. We did integrate the questions they had at the time into this. Today is the first time that we're hearing that there's additional things they would like to look at. And certainly in the spirit of collaboration, we would love to integrate those in. We're not at all saying that we don't want to integrate this committee's thoughts into a bill draft or the licensure board's thoughts in and have those conversations. I would just make the point that I think we probably would like to see a bill drafted so that as we advance those conversations, we're working on paper with real text as opposed to conceptual. So that would be our preference, would be to take what we've done and start moving forward with text edits.
Appreciate that. Ms. Semino, while you're still here, were you planning on testifying this bill?
Mr. Chairman, I was not planning on testifying
All right.
for this bill. However, here I am. I can say for the record that the Wyoming Counseling Association is neutral on this bill. We are tracking it because it is obviously amending our Practice Act as well as influencing our mental health licensing board. I do understand the different language concerns that the licensing board brought up. And I do agree that I think that we could come up with something that a wonderful collaborative moment for this committee.
And you agree to spearhead the effort between the conflicting parties?
That is a lot for a Monday, Mr. Chairman, that is a lot for a Monday. I definitely commit to continue to communicate with the music therapists and make sure that we're all on the right track.
And licensing boards and
Yes.
all the other boards, because there's like 5 or 6 different entities in this section here, so.
So
Thank
the
you.
mental, Mr. Chairman, there are 5 to 6 different entities. All of those entities are included underneath the mental health licensing board. So it would be collaboration with one entity as far as the licensing board is concerned.
Go forth and do good. Speaking of mental health, I'll get you off the hot seat and get Miss Somerville here. We have a whole hospital waiting on us, so I'm trying to get her through this as quick as I can the
Thank you,
next
Mr.
6
Chairman.
minutes. Miss Somerville. Couple of minutes. Don't want to steal your thunder, but we both know how this works. Thanks, Andy.
Thank you, Mr. Chairman. Andy Somerville, Executive Director for the Wyoming Association of Mental Health and Substance Abuse Centers. And Mr. Chairman, I will be very brief just to say that our organization has looked at this. We're in a little bit of a unique position because we employ at our community mental health centers and other agencies everybody that is covered under the mental health licensing board. So we take a keen interest in making sure that that board is working well and that it's working well. We unfortunately have to add our name to the list of organizations that has some concerns about this. And I won't go into those other than to say we will work with the groups and see what we can come up with.
Appreciate it. Questions for WAMSAC? Seeing none. Any other further public comment? Seeing none, I guess committee, the best thing is really just to have a motion on moving a draft forward to our next meeting. Now that you've had an overview of kind of the profession, where it's going, what other states are doing, is that enough information to work on a draft and consolidation? If it should go to a different part of the statutes or not, we can certainly discuss. And maybe LSO could even draft to an amendment that could move it if necessary. Go ahead, Representative Hearn.
Mr. Chairman,
Oh.
clarification first.
Sure.
You're asking for us to move to
Bill draft.
actually start the draft and then move it into the next meeting. Fair enough. I would just note for the record that the licensing board owed these folks a courtesy call before hitting them up in a public meeting. It's just as easy as making a phone call and visiting with them. Thank you.
I did seem to understand from your testimony you had talked to and discussed, but perhaps more discussions necessary.
We did provide the bill draft. We did have a conversation with Joanne Reed. At that time, there were no specific additional concerns. My understanding from that call was that the concerns had been integrated into the bill draft. So, but we certainly want to continue to collaborate with the board on their new to us concerns.
Yeah, well, certainly delicate. All right, with that, Representative O'Hearn, we
We'll do a bill draft and make a motion to pass this forward to the LSO.
okay. Second, someone?
Second.
Seconded by Ian. Any discussion on this proposal for a bill draft? Representative Ward.
Thank you, Mr. Chairman. Yeah, I have a question about the penalty. So the penalty is pretty severe, $750 misdemeanor, then it goes up to 2,000. I have great concerns about that penalty, number one. Number two, I'm not for expanding licensure. In fact, I'm for decreasing licensure, decreasing the number of professions that need licenses, not increasing them. Therefore, I am not for drafting this bill.
Quick question on that. Is it the similar fee across the board for everything under?
Yes, so we were very intentional in drafting this not to take on multiple issues and try to get into opening up all kinds of issues here in the Mental Health Practice Act. So what you'll see throughout, and we didn't have time to go through it page by page today, is we thought the best single issue was just to add music therapy to the same penalties that everyone else is subject to and not try to carve out different penalties. And I believe our preference going forward would be just to make it as clean and simple as possible of saying yes and music therapy as opposed to getting too far into the weeds of which penalties are appropriate. I think that would probably be better handled in a separate bill on looking at that, at penalties as a separate single issue bill.
Agree with that? Any further discussion? Seeing none, all in favor of the motion to have a bill draft to be discussed at our next meeting, please say aye.
Aye.
Opposed, say no.
No.
Motion passes. Division being called. All those in favor, see if Senator Barlow is still around. All those in favor of the motion, if you'd raise your hand. 1, 2, 3, 4, 5, 6. All those opposed, raise your hand. 1, 2, 3, 4, 5, 6, 7. Okay. Well, we will not have the committee pursue a bill draft for our next meeting.
Yeah.
Oh, do you have a discussion, Senator Barlow, or are you voting on the motion?
Thank you, Mr. Chairman. If I could just offer a little bit of explanation on my vote.
Go ahead.
So, Mr. Chairman, and I have been participating in the entire meeting, listening off camera. But I think that there is, since I'm probably the last person to have sponsored a Practice Act bill in the last 10 years probably, and that was for acupuncturists. I think that what was demonstrated today is there needs to be some more discussion about the proper placement. If we're going to move forward with this type of a licensure, I think proper placement has to be a part of that, and then the boards that are responsible for this has to understand what additional responsibilities they may have with a new type of practice. So I'm not opposed to actually taking this up, but I think there needs to be some more discussion. And what I would suggest is the same folks come have those discussions between now and the next meeting and have something that hopefully resolves some of the concerns we heard as the testimony unfolded. Thank you, Mr. Chairman.
Thank you. I would suppose the co-chairman and I, should everything come together, could always put it back on the agenda at the next meeting if we feel it's appropriate and we're there. So with that, we're going to Senator Hutchings.
Thank you, Mr. Chair. And if you can't do it, it can always be a personal bill.
Correct. It is, just one of our 5 topics, so it's tough to take it out of the first meeting, but I agree. Senator Representative Trujillo.
Thank you, Mr. Chair. I do have just one comment question. I believe in musical therapy. Music is very beneficial to everybody's health. What I would like to see moving forward maybe is working with domestic violence victims and pregnant mothers, because we are products of our environment. And if we can help maybe smooth that transition while the baby's in the womb, they won't be born with the same intense moments that the mother is going through at that time, because we're trying to create a better future. And I believe that that's probably a good mental health proposition, is to work with pregnant mothers on domestic violence. So if you can maybe work with that and bring some information to the table. Thank you.
With that, we're going to break for lunch. We have a tour at the hospital. Senator Baldwin, any information you'd like to provide?
Just quickly, nothing about that, but I would suggest that all those parties that we talked about, mental health boards, licensing boards, get together, get back with Chairman Swanisher and I well before our next meeting. And if needed, we'll put it on the agenda for next meeting. Other than that, I don't have any directions for the hospital. I know where it's at.
Senator Dockstader?
But just put in your phones, 901 Adams Street, Afton.
Okay.
901 Adams Street, Afton.
And so those of us want to go, the hospital is sponsoring a quick tour and lunch for committee members. If you'd like to tour the facilities here, again, 901 Adams, we'll meet there in about 15 minutes. If not, we'll come back here at 1:30 and see you then.